and Lena Stolyar, and they are with the Massachusetts Association of Mental Health. So welcome. Welcome to Texas.
Yeah, welcome. Good to have you here.
So now I'm going to start roll. Dr. Amador. Dr. Bob. Oh, you're here. Okay, thank you. Dr. Bobato.
Here.
Dr. Chapa. Dr. Farmer.
Here.
Sonia Gaines. Dr. Goodman.
I'm here.
Dr. Ibrahim.
Here.
Trina Ida.
Present.
Lee Johnson.
Here.
Dr. Keller. Dr. Lakey.
I'm here.
Dr. Liberzon. Dr. Martin.
Here.
Dr. Martinez. Nathan Maxwell. Dr. Mayer.
Here.
Dr. McCullum Smith.
Here.
Dr. Mitchell.
Here.
Dr. Nemiroff. Dr. Newport. Brittany Nichols.
Here.
Dr. Olvera.
Here.
Dr. Pliska.
Here.
Dr. Podewiltz.
Here.
Olga Rodriguez.
Here.
Scott Schlacklin. Sue Shell.
Here.
John Scott.
Here.
Dr. Suarez. Dr. Taminga.
Here.
Dr. Thompson.
Here.
Dr. Wagner.
Here.
Dr. Wakefield. Dr. Williams.
Present.
Okay. That's 23.
We have 23, so we're a quorum, so we can officially begin. Again, good morning, everyone. Thank you for being here for our January meeting of the Texas Child Mental Health Care Consortium. We have a new member, Dr. Amador. It is good to see you here. You want to introduce yourself to the rest of your colleagues across Texas?
Sure. Good morning. Thank you, everybody, for having me. So my name is Dr. Alcides Amador, and I'm a child and adolescent psychiatrist at the UTRGV School of Medicine. It's great to join you all.
Very good. It's great to have you here. A quick reminder to folks, and David Lean just put it in the chat box, since we have to abide by the Texas Open Meetings Act. We really can't use the chat function during these meetings. If you put something in the chat, I have to read it to everybody else in order for the people that don't have access to that have the full content of the meeting today. So again, I would encourage people to raise their hand and we will make sure that all the comments are noted. With that, David, is there anything else I need to say before we begin?
No, that's good.
That's good. All right. It's great to have you here. I don't think we're going to take up all our time today. I think we have a pretty efficient meeting today, but again, it's great to have you here. First order of business, we need to approve the minutes from the last meeting. They have been sent out to everyone. If you haven't read through them, please take a look, but I need an approval and a second for the November.
A second.
Okay. Dr. Podewitz and Dr. McCollum Smith, the first and second. Any further discussion? Hearing none, all in favor of approving the minutes from the last meeting signify by saying aye.
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 Aye. Aye.
Opposed, nay. They're approved. Dr. Pliska, I just saw your hand.
I don't seem to have the link to all the documents. Either I didn't get it or maybe I accidentally deleted it somewhere. I've searched, but can anyone send me that link that has the minutes and the other documents that we have for the meeting or
Yeah.
maybe?
Monet just signaled to me that she was going to get them out. And so we'll get that out and refresh that for everybody. Okay.
Great.
All right. Any other comments? Hearing none, let's go through the beginning of the presentations. And the first one is a follow-up from the last meeting. During our last meeting, we talked about our, communications policy. Lainey McCorkle put that together. I think we had a great discussion. After the discussion, Peter, again, thank you for your input. I had the opportunity to talk to Dr. Thompson and make sure we had clarification in the language. We think we have that correct, but we want to make sure that everyone is agreeable with that. And with that, Lainey, I'm going to turn it over to you.
Sure thing. Thank you, Dr. Leakey. Good morning, everyone. So we added in a paragraph near the top in the purpose section about what this policy applies to. So the materials and the types of presentations. So that paragraph's in there. You all should have that policy. Would you like me to read it out, or what would be the best way to do it?
Can we throw it up on the... Can we throw it up on the screen right now so people can see it?
Thank you.
Okay.
It's the comms policy doc.
Carol, I see your hand. You have a question while we throw it up?
Yeah, can you send around those slides that you just showed to make
Yeah.
to make sure that we have all of the latest of those? It's
Yeah.
important.
I just wanted to say all of the EC meeting documents can also be found on our team site, our internal team site. If you go to the general channel under files, there's an EC meetings folder, and within that folder, all of the EC meeting documents are there, but we will also send a link out.
Thanks so
Also,
much.
On the invitation, when you look at your calendar and see the Texas Child Mental Health Care Consortium on your calendar, there is a link where it says handouts are available here. And if you click on here, you will find all the handouts. But I can resend that to the full executive committee if you didn't click on that. So.
Okay. All right.
Oh.
Here we go.
Great, thank you, Rachel. So it's this second paragraph here about the materials that the policy applies to. It states that it's consortium logos and presented on behalf or representing the consortium or with consortium funds or on funded time. And it does not restrict the development or presentation of materials on behalf of institutions or non-consortium initiatives, and is not intended to impact the HRI academic activities.
So we just wanted to be clear that, this policy in no way hinders our medical schools, the HRIs from doing other activities. We just need to have a policy in place related to the materials and activities that are developed through these state funds to make sure that they are consistent with what the Texas legislature expects us to use these funds for. Peter, any thought on that? Any comments you'd like to make? Peter, if you're talking, I can't.
No, sorry, I was muted.
All right.
No. I think my concern was addressed, and I really appreciate you reaching out to me and talking to me, and I think the policy came out well written and appropriate. Thank you.
All right, very good. All right. So any further discussion? If not, I'll take a motion to approve this document.
So made.
A motion by Dr. Tominga, second by Dr. Thompson. Any further discussion? Hearing none, all in favor of approving this document on communication signify by saying aye.
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 Those opposed, nay. Anybody abstain? All right, we have unanimous approval of that document. Again, I really appreciate everyone's help on that, and especially Peter. I appreciate you speaking up in the last meeting to make sure we got it right. And so that's how we try to make sure we get our business done. So with that, I see that several other people have joined us in the room. Let the record note that Dr. Newport is here. And then Dr. Suarez, I see you have joined us.
I'm here.
Anybody else joined us since we took official roll?
I'm not sure. I got on while y'all were taking roll, but maybe after my name. It's Sarah Wakefield.
Okay. And Nathan Maxwell. Anybody
Here.
else? All right. Lainey, let me go back over to you for the update on the brand guidelines.
Absolutely. Michelle, can you pull up that one now? Perfect, thank you. So with the statewide expansion of PeriPan, we started getting lots of questions from our HRI communications folks about how to combine the branding and what branding they should use. So in partnership with CHC, we decided to do a pretty deep dive into our current brand guidelines doc and refresh it so that it addresses some of the new concerns or questions, and it just kind of meets more needs and fills in some of those gaps. So I'll go over two of the biggest changes right now, but the brand refresh and updates are going to be shared in our communication session at the CPAN PeriPan Summit next week. Teams will get a sort of cheat sheet handouts at that presentation, and they'll also get access to the larger brand guidelines doc. And we'll kind of walk through some of the changes and talk with them there, but I wanted to give this group sort of the initial update. The first big change is just that we are going to incorporate the TCMHCC logo with our other initiatives. And we're going to make that a priority in an effort to create that understanding of how the relationship is between the initiatives and the consortium, and also just to create some trust and some recognition across all of our documents. So these are the different initiatives and their different logos as they will be moving forward from that end of that summit on. And I understand that these are big and there's lots of acronyms and there's a lot of space taken up here. And then when teams add in their HRI logos, that also will take up a lot of space. So I do want it to be clear that there's a lot of flexibility here, and I still am here to support, as is CHC. So which is in that comms policy document, that communications should still be submitted to me. And so I can obviously and always help if we need to have sizing changes or if there need to be exceptions made. I'm totally open to that and understand that that's a very real possibility. Part of this came out also because I do get some communications that have either just the shape of Texas or just says CPAN, and there's very limited mention of the consortium. And so we really want to move to a space where that's clear and that relationship is clear. So these are the logos for the initiatives moving forward. The other change is the color schemes. So we went into more detail. There's some detail on the current brand guidelines doc, but we wanted to update it and make it as helpful and clear as possible for teams. So we've broken up every initiative now has their color scheme. The newest one here is CPAN and PeriPan. So we got a lot of questions on how to co-brand those materials moving forward, how to talk about them, but also just how to have the two logos, how to have the colors. A lot of times folks will create a PeriPan material, but it's still in CPAN colors and they don't think that looks right, or it's combined and it's too pink or too purple. So we created some middle ground here so that teams can have those co-branded materials and really encourage the use of a material that meets your audience the best. So if that's just for child psychiatrists or just for reproductive psychiatrists, or if it's for both, you have a color scheme, you have a logo, so that all those materials can be as appropriate and effective as possible. And again, I'm absolutely here. So if a team has a material that they just need updated, happy to help them work through that, happy to lean on CHC to make some more of those like broader 12 HRI use materials. We can do all of that together. And I understand there's going to be a bit of a learning curve and a time to adjust. So I'm in no way asking teams to throw away any of their current materials or get rid of anything they have already printed. You can use those until you run out. And I just ask that your next order be updated. And I'll be making these changes on any communications I get through that submission form from next Wednesday on. I'll be helping to kind of bring us up to speed and make those changes. Teams will also have all of this available to them after the summit. So we'll go through behind the scenes and make sure that all of your resources in Canva and Teams, wherever you access your materials, that those will all be brought up to date and up to speed. And I'll also send out sort of a mass blast email so everybody has everything in the same place. But those are two of really the bigger changes that'll be coming out of that brand refresh. Any
All right.
questions? Any concerns?
Any questions, David or Jeffrey?
I noticed the research networks were not there, and for CTRN, for example, we've developed a slide format and a poster format. And should we submit those?
Yeah, that would
To
be
you?
great. Yeah,
Okay, I can do that.
thank you.
Very good. Thank you, Jeffrey. Any other questions, concerns? All right. Thank you, Lainey.
Thank you.
Let's next go to the internal evaluation to Molly Lopez and David Lynch. I don't know how you're going to balance the presentation today, or David, do you want to start, or does Molly
thank you.
start?
Good morning. Molly's on remotely, and I'll be giving the verbal update today.
Okay.
Good morning, all. Good to be with you, and Happy New Year, if it's not too late to say that. Just some quick, I said verbal updates. One is that we're very happy to announce we have a new staffer joining us beginning of next month as our data analyst, and it's been a while getting this person on board, but we're very happy to. And so come next meeting, we'll give a more complete introduction and everything. Secondly, I'd like to introduce in person our new TChat program manager, Lauren Rosa, who's here. We introduced her before she started before our last meeting, but she's here in person. So I'd like to give her the floor to give a little background on herself.
Hi, everybody. It's great to be here. My name's Lauren. I'm a recent graduate from the UT Austin School of Social Work Master's Program. So this is my kind of first job out after finishing the program. As part of the program, I was working at the Texas Legislature for the House of Representatives, and I'm really excited to start my position here.
We're very happy to have you on board too. Also, I'd like to say that just as an FYI, our team has been working with Kosh and internal folks, as well as the HRI program staff, reviewing the Access Data's source information on the universe of eligible providers. So it's taken a long time to work with these data because we're getting the raw medical board data and processing it to make sure we identify all the physicians who could be eligible for CPAN and PeriPAN. So you'll be hearing more about that going forward, but I just want to give folks an update that we're working on that. And last, I just hope to see folks next week in person here in Austin at the summit. So I think that's it for us.
Okay. Very good. Any questions for the internal evaluation team? All right. Hearing none. Thanks again to you and Molly for the support and welcome aboard. All right. Let's now go for an update on the research initiatives. And the first one we will give an update on is the new and emerging Children's Mental Health Researchers Initiative. Nagla, let me turn that over to you.
Thank you, Dr. Lakey. So I am going to first give a little bit of a general description of what the new and emerging children's mental health research is, and then give you an update. So this initiative is focusing on advancing the knowledge and evidence base in prevention and treatment of childhood mental illness, and it helps training and research for new and emerging researchers. Once promising and evidence-informed practices are identified, where the findings will be disseminated to inform providers, policymakers, advocates, and families about specific types of treatment approaches that can minimize the symptoms of childhood mental illness. So applicants must be affiliated with one of the Texas Child Mental Health Care Consortium institutions and be a postdoctoral resident fellow or early career researcher. They can collaborate with other institutions outside the Texas Child Mental Health Care Consortium. And the grants are ranging from $150,000 to $500,000 during the biennium, and we're talking about FY 2025 and 2026, depending on the type of grant. So there are 3 types of grant: postdoctoral training, career development, and research. So where are we now? We have, I have 10 reviewers that have agreed to be on the grant. 7 are independent reviewers outside of Texas. And we have our own Danette Castle as one of the reviewers, and then 2 HHSC representatives. The timeline is that right now we're working on kind of finalizing the notice of opportunity, a funding opportunity, which is going to be released and put on our webpage around early February. There will be a Q&A for applicants. Right now it's set up for Thursday, February the 22nd. And again, all these dates will be shared. there's going to be a pre-application process before we do the full application. So the pre-application process is going to open up in March. Folks can start working on it beforehand. So once we release the NOFO, folks can start looking at it. The applicants have to get approval from their chair of psychiatry. And so what we're doing is folks can apply to the opportunity, but they will have to talk to their chairs of psychiatry. And then the chairs of psychiatry will have access to the system and can approve who are their top 6. So each HRI is limited to up to 6 applicants. The pre-application will open up early March 2024, and then the top 6 applicants that are supported by our institution will be invited to apply for a full application in around mid-April 2024, early to mid-April. And then the application deadline will be in May. So just idea of some of the timelines. These timelines, again, once we completely set them and identify the exact dates, we're going to put them up. So that's where we are.
It's been a lot of work. And so thanks, Nagla, for that high-level overview. But she's put together about a 50-page document that goes through all the minutia and trying to make sure we do this right. And for the people that are listening, part of doing that right is we had a lot of conversations with CIPRIT to make sure we understood what they did related to putting grants out and that we don't step in any landmines. The reviewers she talked about, we have a couple of people from in-state, but they're not from the HRIs. And so we have a couple of people from HHSC to make sure that we're going in the right direction with the research related to the needs of the state of Texas. We actually had HHSC put together a list of what they thought were some of the fundamental challenges of Texas so that we can align with what their fundamental challenges in the health system are in this research. And then Danette Castle, again, to make sure that there will be part of the grant to make sure that that it meets the need of Texas. But all the other reviewers will be outside the state of Texas. And so we set aside some of the dollars to be able to pay those individuals for their time. We have people from across the United States. And so we're finalizing that process. I want to thank the members of the executive committee that have been guiding us through this program. We will have just less than $6 million to put into this research. And again, I think we'll learn a lot of lessons to be able to move things forward. And so again, more information will be coming specifically related to the timelines. I know institutions are already working on those. When we talk to you, they're already thinking through what potential opportunities, who the faculty members that they want to support could possibly be. But it's a very exciting time. With that, let me go. I see 2 hands. Dr. Pliska, let me go to you first, and then Madhukar, I'll go to you.
I just didn't catch when the written documents are going to be available and released so we can get everything clear what we want to do going forward.
They will be released early February so that you could start looking, or researchers can start looking at applying before we open up the actual grant software. The grant, I did want to mention, Lachelle has been really instrumental in getting kind of the grant software procured and set up. And so we've been working together on getting that. And so everything, including the submission, the review process, the approval process, the messaging is going to happen through that grant software.
Yeah, so that was a part of the infrastructure that we needed to purchase. It was a IT platform in order for us to do this, we found, I think, a good one that will be able to provide the services all the way through, from putting the application out to review, to awarding grants, to post-review analysis. And so again, trying to be very careful as we craft this together. Dr. Trivedi?
Hi, Dr. Leakey. I think this is fantastic. Thank you for doing this. I am actually, other states are beginning to do it, and California also has a similar program. I am one of their external reviewers, and they were kind of boasting that they are the only state, so I had to remind them that Texas is doing it. But I think this is fantastic because it brings out novel new ideas that helps with our patient care. So thank you for doing this.
No, absolutely. I think, again, we're trying to gear this towards early investigators, to meet the needs for the state of Texas. And, it's something that I hear over and over again, the need to invest in young investigators so they can be successful here in Texas.
Yeah, they had their first review meeting just last week, so this is exciting. Thank you.
It's unique, and I just wanted to add my voice to that. I mean, this type of initiative is clearly, if you look around the country, there is none. It's the same thing like with TCMHCC, the concept, and these type of being able to extend it to the investigators. I think it's big kudos.
Right. It's been no, I appreciate the Texas legislature for allowing us to be able to do this. Olga, it looked like you had your hand up.
Yes, two quick questions. Nagala, can you confirm, you said up to six proposals per HRI? And then can you remind me how many are anticipated to be selected? Do you have like a number versus a dollar figure?
We don't have an exact number because you can have a combination of the different grants, and each grant can vary from 150,000 to 300. So basically it depends on the combination. We do want at least a few from each type, but we're not really restricting the numbers.
Okay. And then the second question, Dr. Leakey, you mentioned HHSE staff provided some guidance on what they see the needs, prevention in this space. Is that something you're able to share with the committee?
I think we can go ahead and share that,
Oh, okay.
that information. Nagala, is that okay? Yeah. Yeah. And again, the peer review process will give us scores, but it's not the final decision. And then it's going to be brought to this group. And part of that is that we need to make sure that there's good balance between institutions and between systems and how these are awarded, since these are state GR dollars. But the peer review process will be part of it. And we'll figure out what we can put together and bring it to this group as a up-down vote related to those recommendations.
Great.
It will be actually, if I'm correct, there will be like 2 steps within a peer review. There will be external reviewers first. Completely nobody from these consortium will be involved, and that's kind of give us objective data. And then there will be internal research group that will be looking on those and making sure that it's reasonably balanced and not 20 proposals from one place and one proposal for another. We have a number of representatives, so it will balance this little group that will be, and then they will come in to this committee with the final thing for approval, because this committee is too big to actually figure out within how to balance that appropriately, so on. But Dr. Nemerov, myself, others, I mean, maybe Dr. Triveri, I don't know, Madhukar, whether you, but that's process will take place, so it's all reasonably balanced.
Okay.
And this is Nagla. Sorry, I misspoke. It's the upper end is 500K for the biennium. But yeah, and then when we bring it here, we're gonna, instead of voting on each proposal, it's to vote on them together, so we don't really put any of the researchers in a bad light.
Yeah. And I guess the other thing, I think we touched on it, is that throughout your institution, there could be individuals that want to apply. There may be people from the School of Public Health in addition to the Department of Psychiatry, but the chair of psychiatry has to make those recommendations of the 6 that they want to move forward. And we do that so we don't become overwhelmed and you don't get surprised. And again, trying to make sure this is manageable.
And we even said that we can, if there is a mentoring, we can have a trainee from one institution, mentor from another institution. So we kind of create network of best available offer rather than a specific institution-wide only.
So I see Dr. McCollum Smith, your hand, and then Dr. Mitchell.
Hi, so can you just review the timeline again? So we'll get the information in February, early February, and then when are the applications due?
So it's a two application process, you can say. There's a pre-application. So the pre-application is going to be, I believe, about 11th of March is when it's opening. We're only giving 2 weeks, and that's the reason why we're kind of releasing it earlier. We have a Q&A because, and the limiting factor right now is more of the grant software, that it won't be ready, but the NOFO will be released almost a month earlier. So then after that, once the HRIs, the chairs of psychiatry, go ahead and confirm their top 6. And it doesn't have to be 6, it could be less, but up to 6. We will go ahead and invite these applicants to do a full application. That's going to be in April, and they would be given about 6 weeks to complete the full application.
Yeah, and it won't be, it's going to be a slimmed down version of an application. This isn't going to be a 100-page NIH grant. It's going to be slimmed down so we can make sure we can review them quickly.
The full application, if you add up all the pages of the text minus the bios and you know, any spreadsheets, et cetera, it's going to be about 12 to 14 pages total.
Dr. Mitchell?
Will you remind me, will the applicants get the feedback from the peer review process?
Yes, we incorporated in there so that there will be some comments back to the applicants. Part of this is really to help researchers in their grant, submission processing and grant research process. So we want definitely to provide feedback, and that's incorporated in the process.
Wonderful. I thought that would be such a rich learning opportunity. So I'm excited that that'll be part of it.
Dr. Wagner?
So just to be clear, with regard to the initial phase of the application, it'll be available on the website, and will it require, is there going to be an announcement to the institution? I just want to see the chair's responsibility. Do we have to reach out to other departments, or will there be an announcement? How will this work? Or individuals just go on the website, just the practicality of getting a wider distribution?
Yes, we would like you to share it with other departments. We've been talking about different ways to share it more broadly on different sites and different email distributions, and working with, I think somebody had suggested that we go ahead and contact your education and training departments to share it more widely within your institutions. So as we get those contacts, we're going to spread it out. So we want to share it beyond even the chairs or the departments of psychiatry within your institutions. But again, the researchers will need to talk to the chairs.
Thanks.
Cheryl, I see your hand up. I don't know if it's from the last question or if you have a new question. Okay, looks like probably from the last question. Dr. Plitzka?
Yeah, one question is, it's 6 applicants per institution, not per department, right?
That is correct.
And then
So,
if a department's chairs say, well, pediatrics says I have 6 and psychiatry says I have 6, do we need to start thinking about how that gets resolved at the institutional level?
that would be resolved at your level, at the actually at your previous level. The chair of psychiatry will need to decide which of the 6 they're going to make a recommendation for funding.
All right.
So,
okay. So even if that's clear. Thank you.
Yeah.
So we have we're incorporating in the actual grant software. We are providing access to the chairs of psychiatry so that they could see all the applications that come in, and would go in and be able to kind of decide which ones are their top 6 and which ones are reserved in case any reason the top 6 don't work out, or we have not enough applications, so you can add more. So we're kind of making sure that you see it. But one of the requirements too, before they even apply, is that they talk to their chairs of psychiatry.
Mm-hmm. Yeah. And again, the reason we're doing that is that's the way the consortium was developed by the legislature. It's through the work for the chairs of psychiatry and the departments of psychiatry across the state.
And if I may add, that also makes sense because, and I give very simple examples, Steve. Let's say we're submitting it and one of the Department of Pharmacology decides to submit somebody, which is perfectly fine. But if they want to do clinical trials or do that, we know that as a chairs who's sitting on this committee, what are the limitations of what the legislator wants and doesn't want us to do, what this money is for. So we can help to redirect already locally what's the meaning, what's behind that, and help people to put the most meaningful applications. Because if we just go in the institutions and people be submitting, I'm sure we have some people who are very eager, but at the same time don't understand what's the consortium was all about, and then the application will not be fitting the call. So,
all right. Any further questions? Seeing none, let's move to the second item under research, the Youth Depression and Suicide Research Network. Dr. Trivedi and Dr. Wakefield. I think we can go ahead and pull up the slides.
You're pulling up the slides. Thank you. Happy New Year, everyone. I think that our work on the network is going well. As you can see on the numbers, I don't need to belabor this. I think we have close to 2,000 people consented, about 1671 enrolled. We are getting almost 2 years worth of data, for example, in 359 people already. And we are beginning to really capitalize on this data. So the next slide. And we can talk about each of the nodes, but I think you have the numbers, you can see. I think our focus this immediately is two things. One is publications from the data, which is rich, and beginning to activate our behavioral activation program. So we have been very busy trying to do this. We have 15 published papers. In fact, between the time we sent the slides and now, we have another 3 accepted. So we are close to 18, and we have a large number of publications in progress. So our goal is, I hope, is that by the end of this quarter, we'll be really getting our baseline data out there in the public domain. People are beginning to recognize this. I think that by the SRN, you can actually go on PubMed and find it. So that has been very productive. One of the key things about these publications, and I'd ask Dr. Wakefield to add also, and that is that all of the nodes and their staff, faculty, and research coordinators have been very actively engaged with all these publications. So it's not just 1 or 2 nodes that are doing it. It's all the nodes participating and, in fact, taking the lead on many of the publications. Next slide. So these are the recently accepted publications. We actually have this a web page that describes each of these and gives you answers to a number of these things. For example, number 14, actually now we have a machine learning approach to trying to identify subgroups of youth that actually have resilience that may be protective factors. And now we will look at their outcomes for this 1 year and 2 year data set is what we are beginning to do as a next step beyond these early publications. So our focus has been on trying to actually produce real peer-reviewed outcomes based on the investment from the legislature. So I think I'm very excited, and I'd love to have other people comment on it. Next slide. As I mentioned, the behavioral activation intervention for teens and depression is new, novel, and we have really done a whole lot. Linnell Goodman, who leads this effort with me, Dr. Linnell Goodman, has done a fantastic job. We have launched it. We have trained people. There's an additional training session coming up. We have already trained 13 supervisors, certified 25 interventionists, and they are beginning to recruit. Next slide. And this is a fantastic program, by the way, that is unique. I don't think there's something like this available anywhere. This is an 8-session program being delivered by people who are under the supervision, but not themselves licensed, so that this is actually a true workforce expansion program. This is very exciting, and people actually around the country are noticing. So I'm going to stop, but let Dr. Wakefield add anything I missed. Then we were given 5 slides, so I can do more, but Sarah.
Oh, I don't have much to add, just that it is very exciting. There's a lot going on. I do share the excitement that in our monthly publication meetings, that there's representation across all of the nodes, and we are having great rich discussions about the questions we're asking and how we can collaborate. And so I think this is just a phenomenal thing to be a part of and to see grow. And we're asking some really great questions for our population to see how we can better improve treatment and interventions and early interventions to address this crisis we find ourselves in with youth depression and suicide.
Very good. Shannon Gangurdy, I see your hand. Welcome.
Thank you, Dr. Lakey. I am attending right now for Dr. Keller. He had some travel delays, so he will be on in just a little bit. But I had a question. The comment earlier was that we're getting out the data in these publications on lessons learned and what's working. Are we thinking about also how to articulate the research to provide data back to the legislature on lessons learned or anything that would be of value to the legislature, or even just explaining what we're doing, how it's working, but then if there's any recommendations there?
I think that's a great question. Actually, I was going to ask a question along the same lines, Dr. Trivedi, to you. I think, again, kind of the way that I think, we're going to be, in about a year, we're going to be in another legislative session. Come this summer, we will probably be called up either through an interim hearing or other ways to come and talk to the legislature related to the work of the Mental Health Care Consortium. We have talked about, and I've seen it done in other areas, simplifications of research studies, with a one-sheeter that has the highlights. But I think, and Dr. Trivedi, correct me if I'm wrong, but I think you told me that you're already working on some of those type of things in development. But I do think for this initiative, and Jeffrey for the other initiative on trauma, we're going to need to start that process of already developing, a couple of slides, not huge, busy slides, but several slides that show the impact of this work related to the care of kids in the state of Texas with mental health challenges. Any comments, Dr. Trivedi?
So 2 or 3 things. Thank you for the question, Shannon. I think that has been on my mind, and I actually communicated with Dr. Lakey and Nagla and others, that we have now a web page and a description and an explanation for each of the papers of what is the message from each paper. I can go on it, but I think we will come up with that. But you are right, Shannon, maybe somebody from your leadership, Dr. Lakey, can massage it in a more digestible manner. I know how to do it, but I think that would be wonderful to do. I think that the findings that we have are clearly likely to change practice in many places. So therefore, how to translate that into language that the legislature will have an easier time, happy to do it.
Yeah, I think it'd be good to bubble it up into those high level messages. And some of the first papers are establishing this really unique infrastructure in Texas across, a very diverse state, across multiple institutions, gathering that information. But Dr. Trivedi, reading through some of the papers, that there are other significant kind of lessons learned thus far related to the impact of depression on kids, the number of kids that have suicidal ideations, and the development of maybe some new methodology to reach out to those kids. Anything along those lines that you want to?
I think we already have papers, and I think Shannon's point is like we need to figure out a way to develop one-page graphics that we can actually identify early who was likely to have suicidal ideation and how to manage it. We have developed resilience measurements that can actually be used to help us segregate for which group of kids we should be paying more attention and which other group of kids are likely to be resilient and therefore can safely be managed outpatient. So I think there's clear kids with anxiety or OCD have a different presentation than those without. Things like that have been published, so I think we can distill it down to more digestible messages.
Okay.
And we have a web page for that. So I think that for this group, at least, I'd encourage you to go to that, because I think there, at least for this group, it is very clear what the message from each of the papers is. And I can make sure to send again Luann the web page, and maybe Monet can distribute to the members of the consortium.
Very good.
Dr. Lakey, I'm happy to help to determine what is digestible to the layperson. I'm probably the most layperson here. So if we need to just have some eyes to say what they understand, what a legislative staffer would understand, happy to help.
No, I think that's great.
Shannon, I have a question about that. Like, so when we think about, we've talked about infographics with some of our things and looking at that. But then Dr. Lakey, I'm also thinking about, we tend to, I think yearly, or maybe at the end of the biennium, submit the report of the consortium. And so are you talking about something outside of that report where you want us to, because we've talked about doing infographics for kind of distilling down the information that we've gotten so far and having those on the website as well for those individuals that, that would be easier. I think that's easier for all of us to see infographics than they are reading through all of the papers. And so I'm just trying to make sure I'm clear on what the deliverable that you're looking for is right now.
I think there's two, and thanks for bringing up the yearly report. I think we can put more information in that. You can put in appendices, put those infographics, list all the articles, and we'll start thinking about the approach to that later on this year. I do think come this spring, early summer, we'll probably be called upon to the legislature to talk about the various things. And we've been, I think, successful in working with the legislature prior to the session to build in into the budget that the key things that we need. And I think they would probably like to have some of that feedback now, several years into the research. And so thinking through on a couple of slides, and I say couple because you don't have all the time you want when you're testifying to the legislature, but a couple of slides related to those key findings and the outcomes that are occurring for each of these, I think would be very helpful as we continue to build the case of why this work is so important. Does that make sense? And I'm happy, we'll talk offline on how we can continue to work, but I think it's time to start thinking about that, because those sessions are going to occur quicker than you think. We're going to be into the interim studies probably pretty soon.
Yes, we will be happy to get any help, and Shannon, I'll call on you also. And the other thing is, remember, we originally started claiming we want to do a Framingham type study. We now have one. And so I think we have to convey that message, because nobody else in the country has that for kids. And so how do we convey that? Yes, absolutely.
Dr. Tominga?
Yeah, thank you. Thank you. I appreciated having us all see together Maduker's depression, his numbers and proposals of depression. When we started these out, we do have two now of these kinds of consortium around the state, one in childhood trauma and one in childhood depression. And I think especially putting those side by side, David and Shannon, and give the legislature a real concept of the scope of this as it covers the disorders in children is really important and wonderful too.
And I think to your point, Dr. Temminga, is that the other thing is that we have been talking, and now maybe in the next 6 months capitalize on that. We have really common approaches. We have measurements that are both similar in both the networks, and trying to kind of cross-pollinate in terms of research questions is what Charlie and I have talked about already. And so that could be the other thing we can do.
So what I'd like to,
They're using
what I'd like to do now, Dr. Trivedi, is transition over to the other research study. I think that was a good segue, Jeffrey, into the work that you guys are doing in trauma. And I know you were ready to jump in this conversation, but I thought it'd be easier just to go over to you and have you present your work, and then we can have an ongoing conversation. Thanks.
Oh, good.
That'd be great. And I'll go ahead and share the comment I was going to share while the slides are being brought up. I think in addition to taking the research findings and communicating those in lay language, to share the impact that we're having on the field, I think one of the things that occurred to me during the discussion that the legislature might be interested in hearing is how the research networks have been a conduit for children who weren't previously receiving care to receive care. And we have that information that we've collected. And I think that would be low-hanging fruit, not necessarily something to publish in a psychiatric or medical journal, but something that I think would be of keen interest to the legislature. So with that, here's the slides for the Childhood Trauma Research Network, and we're up over 2,100, closing in on 2,200 baseline completed visits, and you see the rates dropping down below. A 2-year follow-up by now, because I collected these data over a week ago. I'm sure we're up over 400 year 2 visits, so we've got excellent retention along the way. Very pleased with that. Next slide. And this shows the month-to-month baseline visits, and you see that drop off that happened there in 2021. And the explanation for that was that occurred as more and more of the effort was being devoted to the follow-up visits. So that was expected that was going to happen. And after some struggles during mid 2022, we've done really well since that time, and averaging in the 50s new baseline visits each month. And that's going to sustain us going through. So we're very, very pleased with ongoing recruitment. Now almost closing in on 3.5 years out. Next slide. This is the same information, although not just for baseline visits, but all visits month by month. And you see we're up over a total of 7,000 total visits across the 3.5 years of the study. And our objective is to be averaging around 200 total visits per month. And by and large, we've been able to achieve that. Had the anticipated downturn in December due to the extended holiday season, but are headed towards a really good month in January, on track to complete 220 visits this month. Next slide. This is where we are with regard to publications. So we have 3 that are published, 3 more that are in various stages of submission. In the second table. So one of those has been reviewed and has been resubmitted, and we anticipate getting good news on it very shortly. The second one by Cody Dodd at UTMB is under revision after having gotten journal reviews, and will be resubmitted shortly. And then the one from John Larry, and very high impact journals. Very pleased with that, as Madukar and their team is. And then we've got a variety of others in various stages of development and nearing submission. So very, very pleased with how that's unfolding. Next slide. The new biennium, our new development in CTRN has been the addition of trauma-focused cognitive behavioral therapy. And with some funding from provided by ARPA, if memory serves me correctly, we were able to initiate training of therapists. And you see on the far right where that training stands. So the training to be certified in TFCBT, the requirement is that they have, the therapist trainee has completed 3 cases. To be given the green light to do study cases within the research study, we have set that they have to complete at least 1 training case, and then thereafter they can proceed. And so you see what, 1, 2, 3, 4, 5, 6, 7 of the 12 nodes have at least 1 therapist who has completed training and is ready to start seeing study patients. The other hurdle to getting ready to go has been achieving the regulatory status. And down at the bottom of the slide, it's a multi-step, very convoluted procedure where we submit the protocol to the central IRB, which is based at UT Southwestern. And all of that's been approved, was approved back in November. They then send reliance agreements to the 11 other local IRBs, who then review that and send that back to the central IRB that then provides final approval. And you see 4 of the 12 nodes. Final approval is actually coming in today as we speak. And so we've got 2 nodes, UT Health Science Center of Houston, a UT Medical Branch that this week will begin recruiting into the TFCBT study. And we anticipate the others coming online in a matter of just a few weeks. So we'll be sticking our toe in the water in this next iteration of CTRN here in the coming days, and anticipate being fully operational very soon thereafter. Next slide. The other thing is, in terms of workforce expansion, is that we built into our budget this year ongoing therapist training and trauma-focused CBT, which is a dire need in the state of Texas. The selfless interest to CTRN is this provides us additional therapists, trained therapists at each institution who will be available in terms of one of the current therapists, for example, takes an extended medical leave or leaves the institution altogether. We'll have people at each institution ready to step in. And so currently, in the cohort that's starting later this week, we have 8 therapist trainees from the institutions you see listed there. And then we've got 5 subsequent cohorts over the course of this biennium who will be starting. Our goal is to have about half a dozen, 6 to 8 therapist trainees entering each of these cohorts. And so there should be a robust expansion in terms of availability of trauma-focused CBT for kids across the state of Texas as a result of this. So we're very, very pleased and proud that we're able to do this. Next slide. This is a look at what we're seeing in terms of baseline diagnoses. Each of the diagnoses going from left to right. The blue bar shows what's for those that it's the primary diagnosis, and then extending further up tells you all who have that diagnosis. So currently about 500 of the 2,000 didn't fulfill diagnostic criteria for mental disorder. PTSD is the most prominent. It's also about 500. And for the vast majority of kids who fulfilled diagnostic criteria for PTSD, that was the primary diagnosis. If we go ahead and go to the next slide, and we'll see the same data. The y-axis, though, here is percentages. So 25% of the kids had no diagnosis. 25% PTSD was their primary diagnosis. 31% or 32 overall with PTSD. And you see the numbers from there. Anxiety disorders collectively were the most commonly encountered. Nearly half of the kids, 49% fulfilled criteria for one or more anxiety disorder, generalized anxiety, panic disorder, so on and so forth. But as you see, often that was not the primary diagnosis. And most commonly, the primary diagnosis in those kids with an anxiety disorder was PTSD or major depression. And then you see some of these other disorders that are not necessarily a result of the trauma, like attention deficit disorder, but may play some role in susceptibility to exposure to trauma, which is, of course, one of the things that we're going to be looking at in analyzing the data. Next slide. And finally, the request was made from the executive committee sometime back for us to gather data with regard to the children in the study who have been exposed to trauma. Were they engaging in violent behaviors themselves? And so we have been gathering that data. We're now up to 442 kids from whom we've been able to gather that data. And I'm just showing you here there's no analyses of, with p-values or anything like this. I just pulled this together in anticipation of this meeting to show you what the breakdown is. And so the left column, these are the different violent or violence-like behaviors that the children were asked about. And then across the top, the various types of traumas that they had experienced. And this is focusing on that trauma that they described as the worst trauma. And clearly what we see is those kids who directly experience physical abuse or physical violence, much higher rates of them engaging in perpetration of violence themselves, threatening others, harming others, starting fights, vandalism, and so on and so forth. And you see the numbers across the other categories there. I have to confess, I was surprised, although perhaps pleasantly surprised is the way I should view it, that none of the kids reported having forced others into sex. That's either very good news or it's that they're not willing to share that information, if that's the case. But you would think, kids would be very reluctant to share, for example, that they've harmed animals, and yet some were willing to share that information. So, so some interesting initial results here, and we'll be sharing this with our group. And I think we're about at the threshold to actually do something with this and turn this into a publication. So thank you. That's all I have.
Dr. Wakefield, I see your hand.
Yes, thank you, Dr. Newport, for presenting that. I think it's very interesting information. I had a question about the last slide, not the specific information on the last slide, but thinking through if we're missing a subset of kids because we're likely not enrolling kiddos who have contact with the juvenile justice system at the moment. And many of those things, if they had engaged in them, could or likely would result in some form of charge in connection with the juvenile justice system. And so I wondered, and thinking through that may be skewing those to actually be less reflective of some of those sequelae of kids having trauma, and especially the one that you mentioned, the forced sex one. So I wanted to ask you if y'all had thought through any IRB modifications to be able to include kiddos who had contact with the juvenile justice system, or how you were working through that, as that likely will skew that data a little bit differently.
Yeah. We haven't, that's not been something, Sarah, that we've discussed recently. We certainly had, long discussions about it when we were devising the protocol. And one of the concerns was where there were pending legal charges, either, through, with the child, being victimized and legal charges with regard to that, or the child as perpetrator, decided that was a thicket that we wanted to not wade into, for a couple of reasons. One is being pulled into legal matters, But then the other is there's then some potentially some incentive to misrepresent when legal charges are pending. So I think, you know, your point's well taken, and if anything, the percentages are probably higher because we're not recruiting from that group. I want to, Karen, is there anything that you'd want to add to that?
No, I think you articulated very well the reasons why we didn't pursue that in there. And I think obviously if a paper comes out about this, we need to discuss that certainly as a limitation. You raised a good point, Sarah. It was just, we didn't want to have legal entanglements tied up with the research, given where we were at the time.
I am wondering about the ability to maybe in the future look at kids who are post adjudication. So I totally understand if kids are pre-adjudicated and they are, you know, in the middle of those legal decisions. But thinking if they're post adjudicated and they're not incarcerated at the time, but potentially on probation for some of their behaviors, the majority of the kids that I interact with are on probation for many of these different charges, but they're post adjudication to that program. And so that could be an opportunity to look at that a little bit more closely, because that's my number one diagnosis of all the kiddos that I see in the juvenile justice system is trauma. And I think it's a really important story to tell so that we can intervene as early as possible for these kiddos. So I appreciate this data so much, but I do think that it likely is underrepresented of the issue in our state.
Lynn?
First off, I just want to say thank you so much for these presentations. I've had the opportunity to go around the state and talk about what we're doing at the consortium. And whenever I talk about the research piece, one of the questions that always comes up, Jeff, is how can other providers in Texas benefit from the trauma-focused CBT training that's happening through the consortium? There is a recognition that other providers of other like nonprofit organizations and LMHAs and other providers of services to children with mental health needs and their families would love to be able to also have trauma-focused CBT training. And so it's something I think we should think about, whether the individuals who are being trained through the consortium can maybe at some point also serve as trainers for other providers so that we can spread the availability of trauma-focused CBT across Texas. I think that's one of the goals of our research projects is how can we use what we're learning and really build the system of care for children in Texas who have mental health needs. So it's just a challenge for us, I think, to think about how in the future, in terms of workforce, recruitment and retention, being able to train clinicians on new and innovative types of service approaches is really helpful for that. So just something for us, I think, as a consortium to think about in the future. And then the other thing, in terms of, to Shannon's point of how to communicate our messaging around what we're learning, we have to also think about the practical application of our findings to the provider system in the state, so that the evidence that we have about what we're learning, about what works to address these issues in children outside the scope of the children that are involved in our research initiatives, and how can we use what we're learning to inform that broader provider system about what works so that other providers across the state can use that and apply those approaches for children that they're working with. So just a challenge for us, I think, to think about how to communicate those messages and spread the wealth of what we're learning across the state.
So if I may add, you have an excellent point, Luann. We're all thinking in terms of train-the-trainer models in general. The issue here is that in order to expand that further on, you really need a next level of training. It's not enough to train providers, as Jeff was describing. You need to train now the consultant from within the providers.
That's right.
How to consult, how to do that. That's a very long and relatively it's not a it's doable, but it requires a specific effort. And one case will not be sufficient. Right now, we are getting them out, or the network gets them out to provider within one completed case. But in order to be trainer or consultant, what they would call to that, you need to have extra layers of patients that you've seen, and then supervision.
That's right.
That you're doing. So it's a little bit more complicated. And why I'm saying that, not only that's a second layer that requires extra time, but it also requires extra resources. Because that, what you're talking about right now, it's an implementation. And I think implementation has to be seen outside a little bit of the current research network, simply because of the funding. I mean, this requires extra time and extra funding. So if we are serious about that, we should actually put it as a separate theme for the next budget, legislature, and so on, to carve out that, so it will not be hitting the research networks. Research network will provide the core expertise, but implementation on a large scale will require additional funding. That's all what I had to say.
Yeah, I appreciate that. I understand that completely. I think that's our challenge, right? So, but I did want to bring it up because I think it's important for us to think about from our workforce and recruitment and retention perspective. One of the things as a consortium, we've been talking about that a lot, and have had some meetings, and we had our white paper last year. And I think it's a continual discussion across the state, how to recruit and retain, and frankly, how to train our providers on the latest research, what works for children, so that we can do more measurement-based care, target our approaches according to the diagnoses that children have, and really target those treatments. And so I just wanted to bring it up as a challenge for us, because I think it's something that we have to think about on a regular basis. So thank you, Dr. Liberzon.
I want to second Israel's commendation of what you had to share, and I think certainly investing some resources into having someone certified not just to deliver TFCBT, but certified to train others in it, based here in Texas, would be a boon for the state. One of the other things that occurred to me, as you mentioned, there are those outside the 12 HRIs across Texas who are interested in this. That occurred to me, and I'm curious, Dr. Lakey, whether this would be something that would be permissible. We've got those cohorts of additional training opportunities scattered over the next 18 months, and our goal is to fill each of those with 6 to 8 therapists. It's quite possible by the time we get several cohorts into this, that amongst the 12 HRIs, we may not have enough people to fill all of those slots. Could we reach out to other institutions based in Texas outside of the HRIs to invite them to take advantage of that training opportunity?
I think we need to talk about the details, but there's ways that you can reach out to other institutions.
Okay.
And let me go to Dr. Trivedi, who's been patient, and then Olga, and then to Israel. So Dr. Trivedi? Dr. Trivedi, you are mute.
I had a question for Jeff, but in the meantime, I think Luann, you raised an important, and we are running into this already because of people in at least North Texas are hearing about our behavioral activation, and like we are beginning to have conversations with the Tarrant County MHMR. They want to get some of their folks trained in behavioral activation. So we'll have to, going forward, figure that out. I think this is going to be a resource. So we have a training academy that does that. So we can talk offline. But the question for Jeff, I think I saw your data. It's very exciting that trauma is associated with PTSD. Everybody agrees and knows that. But in fact, if you look at the data, it's actually depression is quite the same, not as common as PTSD, but MDD is almost there. So maybe at offline, we should discuss some way to collaborate and do some combined analyses because that may be the biggest impact of trauma, and let's not as big as PTSD, but still MDD sounds like a big risk for those who have been exposed to trauma. So maybe I see Jair agreeing. So we should talk about that.
Good idea.
I'll just reiterate, yeah, wonderful idea. I think that's an excellent opportunity for cross-network collaboration.
All right, let me go to Olga and then to Israel, and then we're going to go to the next part.
Sure. I had a question for Dr. Trivedi and Dr. Newport. Do you think it's too early in the research, or do you think you have enough time in the research to really discuss the public policy implications for your research on what solutions we can take to who and when, is my first question. And my second question is, I know that, we're funded by the legislature, but there are a lot of other entities out there that receive a substantial amount of money to make changes in public policy, like the Department of Family and Protective Services, where you might get early interventions, and all the different programs that HHSC funds that have a lot of prevention and mental illness. So the first question is it too early for some public policy solutions, specific public policy solutions that we would recommend? And then two, besides the legislature, who else would we target or who else would we inform even before the next legislative session begins? So Dr. Newport and Dr. Trivedi.
Yeah, I think based upon the baseline data, which I think in both networks, the reports that have come out, the data that's been most systematically evaluated is the data at baseline. Certainly has implications for policies regarding subject screening and identification, those kind of things. So I don't think that would be premature at all. I think in terms of policies regarding interventions, we need to transition, both networks need to transition into the longitudinal data that we have and seeing how things transpire over those 6, 12, 18, 24 months of follow-up. But with regard to screening practices, those sorts of things, I think in both networks, we already have in hand an abundance of data that could speak to that.
Thank you.
Okay. Israel?
Well, just reflecting on that, our discussion here, it reminds me very much, mirrors what I'm going through with the process that we have funded to train trauma therapy in Ukraine right now. So we started and we're working very actively on that, first of all, by training the providers first. But immediately we move into the question how we train the trainers and what is the mechanisms and how to do that. And this is where we're standing right now. One of the critical questions that we have to keep in mind when we're moving from one process into another is what are the barriers? Because the barriers are complicated and multiple. And in order to look on the barriers, for my NIH grant that I was talking about, I had involved intensively School of Public Health and people who implementation scientists. You just met one of them last week, and we are working hand in hand with doing clinical training, implementation, which means follows up and see how this actually in reality is this training take place, rather than, because it's easy to set a tag and go train and so, and then nothing really changes. And that's not what we want. So in my mind, the next step, if we're serious about training the trainer and do all that, I would strongly recommend for us to pull on our additional colleagues who are expert in implementation research. For example, simple thing is studying the barriers. One has to, before we do as we do implementation, we need to study the barriers. So that's the place, and I think we should highlight that to legislation, where the clinic and the research are very intimately involved. We all the time splitting that, for the legislation. But here, The implementation research is exactly what will drive the clinic, and clinic will be critical to be able to get the data for the research. So for us, I think this is the opportunities where, as we move forward, if we especially focus on that, to demonstrate to legislator is that how the research and clinical intimately involved. And since I'm doing it in another place, I'll be happy to assist with this process of bringing the excellent implementation researchers who are actually interested in exactly the same question, which we're doing in Ukraine and so on.
It might be a good research study for a junior investigator for a new and emerging children's mental health.
Yes,
idea.
I think you might get some applications.
Those are, yeah. All right, Dr. Wakefield, let me go to you. Sarah, you are on mute.
Yep, sorry, I lowered my hand instead of hit my mute button. I wanted to make a couple of comments to the question right before that about what do we know so far and what are the implications. I think, that when I look at these studies, the things that are presented over and over again in the trauma network is that there's so many kids who are referred to that who were not previously getting care. I think that's really important information for our legislature, that these kiddos with serious diagnoses, PTSD, major depressive disorder, significant anxiety, many of them weren't previously getting care. And then in the Depression and Suicide Research Network, where they have to be receiving care to be enrolled, they're still very sick. And then it's very hard for families to stay in care. And so when I look at this about the ability to talk to the legislature or anyone right now, that we do know early intervention, so that screening, we know measurement-based care so that we know how these kids are actually doing, and then evidence-based interventions, which both networks are working on, and case management to try to help support these families. And so I don't think it's too early for us to say those things. We have lots of other work to do where we're trying to understand better algorithms. But I would say, Dr. Trivedi and Dr. Wagner, Dr. Newport, if you have other things to add, but those are the things to me that we can immediately say, and we can say resoundingly.
Thank you, Sarah. And I think those are the type of things that we need to start putting into a separate document to be able to talk to the legislature about. And so that's the challenge for all of you that are involved in the research initiatives, that in academic arenas, number of publications, impact factors, that is your credibility. It's not necessarily with the legislature. That is something we can put down there, but we need to make sure that we can articulate well what has happened over the last several years. And I think it's okay to say that we've been establishing the infrastructure, characterizing the data sets, but the things related to the large number of kids that weren't in care, the challenges that we're identifying, the large number of kids with depression, suicidal thoughts, et cetera, and how that could potentially impact policy is where we can continue to build this and the kind of the verbiage that's going to resonate with our funders for this. Okay. With that, Dr. Wakefield, I'm going to go to you for the update on PeriPan.
All right, as they're pulling up those slides, are they already up? Sorry, I'm like 2 slides. There we go. All right. Dr. Trivedi, did you have one other comment? I think I cut you off.
It's okay. Go ahead.
Okay. All right. Well, so I'm excited. I have a lot to talk about in PeriPan today, and I'm excited to talk about it. Wanted to give you this snapshot slide as we continue to work across our state and have amazing participation from all of our health-related institutions. It's really been such a privilege, as I think I say this every single time, but it is true every single time, about the work that is going into this and to try to advocate for treating our moms, which we know is the primary prevention strategy for supporting and treating our kiddos, or preventing them from needing treatment in the future. And so we have worked together. We don't have a reproductive psychiatrist at every single health-related institution. So this has really been such a collaborative effort across the state to learn how to really coordinate with each other as we've been trying to build all of this infrastructure and learning all of the lessons that we learned in CPAN to expand this service to serve our pregnant postpartum moms. So looking at it, it's not surprising our consult volume went down a little bit in December. And so we're continuing to look at that. Of course, it's trending up overall since we've gone live with every this service being available across the state since September. But had that little dip around the holidays when lots of people are out of clinic. We continue to see an increase in our called once and our called multiple times volumes. I have some other data on clinic staff roles on another slide. I believe we are increasing our number of consults overall. And then are recommending changes in medication or diagnosis at almost 30% of the time. And then about 50% of the time providing information about referrals and resources within our within the relative community or respective community. Next slide. So just wanted to show you the physician call activity. I think sometimes we forget how often pediatricians are tasked, like pediatricians are actually tasked very often with looking at screening our postpartum moms because our pediatricians and American Academy of Pediatrics knows how important it is to child's health, overall health and mental health for a mom to be treated and well. And often a mom is seeing a pediatrician more often than she's seeing her obstetrician. And so we see obstetricians are still calling the most, pediatricians the second. We do not have the residents broken down by clinician specialty. That's something that we're talking about being able to do so that we can look at that. We have some psychiatrists calling, and then we need to do more outreach, I believe, in our family medicine colleagues, at least out here in West Texas. Many of our family medicine colleagues are providing obstetric care. That's not true across, in all areas of the state, but in our more rural places, we know that is happening. And then sorry, I was going to make this about 67% of the calls are from physicians. So we are excited about that. So peri-pan enrollment activity, you see in 2022 when we were live in 4 health-related institutions. And then when we went live in September, you can see that we have continued increased enrollment. All sites are working very hard to go out and talk with their obstetrician colleagues and those providing care to our pregnant postpartum moms. And so we continue that across the state. Next slide. This is our ECHO series. Just wanted to remind everybody we have a robust curriculum associated with our peri-pan service. So it's education in as many forms as we can do education. So some of the education happens on the phone line when someone calls and it's about a specific patient. Some of the education happens in webinar and ECHO form. We have webinars monthly all year long. And then we have ECHO series that are a little bit more short burst, really a little bit more intense, more case presentation, case specific, group learning experience, interactive. So we have our spring ECHO series coming up and you can see the topics here. Next slide. Which I will say, you don't have to go back to that slide, but I will say the last one in June is postpartum catatonia. We've actually had a fair number of discussions in our psychiatrist meetings about postpartum catatonia, and with many of us running into this across the state. And so that is a very complex diagnosis that requires many different disciplines, and we are all seeing postpartum catatonia across the state, which is an interesting thing to be able to get. When you're only seeing it yourself, you see very low numbers, but when you're having these collaborative discussions with your colleagues doing the same work across the state, it's interesting how much that's coming up on our differential, and maybe something we need to actually take another look at. Here's our grand rounds, our webinar schedule. These are our monthly topics. So we are well into this. Our next one will be March 19th. We repeated the topics from last year so that we could, knowing that we were expanding statewide, we've always had these open all across the state since the launch of the program, but now with active efforts in all areas of the state to engage our clinicians, we know that they're more aware of these. Next slide. So I wanted to talk about two really exciting opportunities. One that was presented last executive committee, and I just wanted to tell you that we are working towards this. So if you come to the summit, you'll hear more about this collaboration and with Be Well Texas and HHSC. So we joined an application for a grant focused on substance use disorders in pregnant postpartum moms. As a reminder, overdose and suicide are the leading causes of death in the first year postpartum, but overdoses are a higher rate than suicide. So we typically think that overdoses are and substance use is often linked with a mental health condition. And we want to intervene as early as possible. So we're working together to create a linkage between PeriPan. If someone calls us about a mom who's having substance use disordered behaviors and needs assistance with that, to be able to link very quickly with a list of resources and interventions that may not be available in that mom's area of the state. And then also we're working on developing resources for those frontline clinicians. So how would they educate, what kind of materials? And I think this is going to be really, really exciting for all of us and move the needle considerably on just information and education for all of our clinicians across the state, information and education for our patients across the state, and then also increasing access to care. Next slide. All right, I kind of already, so these are all these different things. If you come to the summit, you'll see a fantastic presentation by Joy Borges from HHSC and some of our team members from Be Well Texas. It'll be really exciting, and they'll present a lot of different things that have been done across the state for focused on substance use disorders across the years. Next slide. I just wanted to outline and have you have this in your slides, what those goals are for the this project. So I've already, I think I've already talked about what is on this slide, but this will be statewide, focused on women with substance use disorders, and establish that linkage between PeriPan and existing services and expanding access to those. So that we talked about last time a little bit, but I did want to tell you that we are working on that. We are actively meeting to develop that. We're going to kind of introduce it in a broader sense, this collaboration at the summit next week. And then teams will be hearing more and more about it. But the primary role of our PeriPan teams will be to receive this information, to be knowledgeable that this information, these linkages exist, and then be able to share that with the broader communities when they're sharing other resources and when the psychiatrist is on the phone talking about with a clinician about the symptoms of a woman if they thought they needed these services. Next slide. But this is a brand new thing that we've talked about previously a little bit, but I wanted to talk about today and get input on for if this is something that everyone thinks in the executive committee that we should move forward with. I'm really excited about. So Pathways to Perinatal Health Equity Study is a study that Lifeline for Moms has gotten awarded a PCOR grant for next slide. Let's see if there's more information so I don't tell you everything about it before I get to the slide like I did last time. So this is a comparing healthcare system approach to healthcare community partnership. The idea is, so we know that McPat for Moms in Massachusetts was the first perinatal access project. And we've been working with Lifeline for Moms, who's a similar group, and some of the founders of that McPat for Moms program that helps state launch their own perinatal programs and use lessons learned from across the nation. And one of the lessons learned is that it's really hard for anyone to incorporate an access project into their day-to-day practice because everyone's so busy, and it's exceedingly hard for obstetricians to do that. So I want to say great job, teams, getting obstetricians to call. They're our number one caller, so it's really great. But we want them to call more. We want to be fully utilized. We want to help as many women as we can across the state and as many clinicians serving those pregnant postpartum women as we can. And so some of the data that Lifeline for Moms, McPat for Moms has gotten in the past is that if we really help integrate into that practice algorithm for that clinic, that it is much more likely that they'll know when to call the access project and they will call. And so recently there was released an AIM bundle focused on perinatal depression, perinatal mental health disorders, about screening and recommendations from the American College of Obstetrics and Gynecology. And what this project proposes to do is to go to partner with a clinic, and several clinics actually, and then say, we want to help you implement that AIM bundle. And we want to do that. And part of that AIM bundle is helping you know when to call PeriPan. And so in this, there would be two different things that would happen. One is called PRISM, and that is actually the what I just talked about, implementing that AIM care bundle and helping that practice do that. We think that we are, as we're starting up PeriPan and our clinicians have more time because our call volume is lower than we expect it to be in the future, that this is a great time to actually do this and partner with clinics to help them implement AIM bundles. The idea is that this is a train the trainer model. Our clinicians, our psychiatrists, our teams, our PeriPan teams will learn this, and then we'll be able to see one, do one, teach one, and then know how to do this with clinics in the future. And then the arm 2 is the PRISM plus PSI peer support. The peer support specialists and PSI are actually being trained in behavioral activation. You heard about behavioral activation earlier because we've launched that in the YDSRN. And so in arm 2, it's the implementation of the AIM bundle plus the PSI peer support, which that part doesn't require anything from the PeriPan team, but that woman would be offered the peer support through PSI, and so they'll look at those. So the next slide. They are partnering with practices across the state. Next slide. Across the nation, goodness gracious. And so there will be virtual implementation. Each access program will implement PRISM with 4 to 8 practices per state. There's grant support for the access program and the obstetric practice. The Lifeline for Moms will be integral in actually training the obstetric practice, and we'll watch that training and then learn how to do that. And that's the see one, do one, teach one model. And then there will be opportunities for our psychiatrists and clinicians within our faculty to participate on some of the scholarly activities associated with this as well. Is there another slide? Can't remember. Oh yeah, okay. Snapshot of the project timeline starting in March, excuse me, and then planning phase for about a year to identify clinics, identify the training or work on the training, and then research phases, which will primarily be with the obstetric practices. They would have to agree, and that would be directly with Lifeline for Moms with a project end date of 2/28/31. I think that is the last slide. Yes. So the overall summary, just because that was a lot of information, is that we would, as an access project, be asked to be trained in this to help identify clinics that might want to participate within our region. However, it's interesting, there are already clinics in Texas that have contacted Lifeline for Moms and said, we are interested in doing this, but it really has to be in conjunction with the access project. That's the goal, is that you're utilizing access projects. So you're utilizing PeriPan to train these clinics how to implement the AIM bundles. And then we, Dr. Potowitz, I'll see your hand. And so that we work with Lifeline for Moms to learn how to train them. Then we train one with Lifeline for Moms, and then we know how to do it. And we can do that in the future for other clinics across Texas. Dr. Potowitz.
So let's go to Alan and then we'll.
Okay, go ahead, Joe.
Dr. Potowitz? Did you have a comment?
Yes, I do. I clicked raise my hand and put my hand down, and I thought it was like the mute button. Sarah, great stuff. I have the opportunity to maybe make some good changes within a practice that I know of well within my institution. Is there a way for you to give me information that I could just do a drive-by, let's talk, and then let them get connected with you? Who would they go to after I make this introduction? Who's
Yes.
next? Who's
So
next?
first question, the first step would be saying that the consortium does think that this is something that we should do for Texas to increase both the access to PeriPan and increase, improve that measurement-based care, improve the screening within these clinic settings. And so once we have, I'm hopeful for everyone to say, yes, they want to do that. And if we want to do that, then next we would work with Lifeline for Moms in this planning phase to identify 8 clinics across our state as these first identified clinics. And then, and there are certain, so they can look at if they're a good, if they meet the criteria for being one of these startup clinics. And then they would do a training with them. On one of them, we would do a training where they're watching us, and then we would do additional trainings, and then we'd be able to train any clinics throughout the state that we wanted. And so if you think you have a clinic that would be interested in being part of this project, that I think we will, if we get approval here, then the next step would be us taking that information in. We would say who has clinics that they think might be interested, and then we'll give that information to Lifeline for Moms.
Israel?
Sarah. Hi, Sarah, very interesting. What I was missing to understanding in this project, first of all, is it already funded or it's application?
It's already funded.
Okay, I have a couple of questions. And who are the PIs and on the process?
So Nancy Byatt at Lifeline for Moms in Massachusetts.
Uh-huh. So she's the one who would the PI. Okay. And the other question that I had is, so I don't really, what's the outcome in the comparison group? Because that's to me was not clear. I see what aim 1 and aim 2 is examining, but what is the outcomes and how you compare that to, because I didn't hear anything about treatment as usual. I didn't hear anything about, so can you speak about it a little bit?
Yeah, sure. So this is really, it's a PCORI grant. And so it's really about some of this implementation and how we get better uptake of the Access project and implementation of utilizing screening measures and comfort level within the obstetric practice. So the outcomes are really from the obstetric practice, and there will be different surveys and measures that are sent to the obstetrician who is participating and their clinical practice who are participating. They would be fully consented with the Lifeline team about this in the research phase. About doing those surveys. And then the comparison is, the PRISM, which was the original model that MCPAT for Moms did, that showed increased comfort level in Massachusetts and increased utilization of the MCPAT for Moms access line, utilizing that. And then PRISM compared to actually receiving focused peer support with behavioral activation.
So some of the sites of the 8 sites or 8 clinic will be running the PRISM only, and some of them will running PRISM plus Access or not?
No, everybody's running. So an Access, so the PRISM is the ability to, or it's really implementing, helping a practice go in for, helping a practice look at how to implement the AIM bundle, when to screen, what education materials to give, when a woman is screened, at what point to refer where. So if she's screened as mild or moderate to severe or severe, on the screening measures, what are those recommendations with that screening? And in that way, we've seen that utilizing, if someone screens mild, but they need some psychoeducation, that we can help the practice have materials to do that. If someone screens moderate, and there's a question there, and the OB has a question about medication, that we would recommend that they call PeriPan. If they screen severe, where would we direct them for the different services? So that's really Lifeline going in and doing that for the first one, and understanding what is the result of each screening cut score. Hold on, I think I forgot your other question. Oh, Prism.
that
So
was-
Prism or Access. So everybody's using, we're not doing anything different for our Access project. We're just being available to answer the phone call. But in implementing Prism, we are advising that there are these different places that we would recommend you calling PeriPan as a part of your treatment or your clinical flow. The two different is Prism alone, which is what I just described, or Prism plus a woman being referred to Postpartum Support International with a peer who is trained in behavioral activation as a peer support.
Yeah. So, but Prism alone will not be running actually. Or
So Prism
It-
alone, yes, would be running.
so one of the 8 of those clinics that you want to be, do you want to recruit in the state will be running Prism on alone? No, they all will be through you. So they will all have this access, right?
So Prism is an kind of a framework
Right.
where
No, I understand, but I mean, so where do you go collect this Prism alone data? That's what I'm trying to understand.
the Prism, let me see if I can, I think maybe I'm not explaining this very well. Prism includes the algorithmic step to call the Access project.
Mhm.
We're not PeriPan is not collecting data from the obstetric practices. We're just helping identify some obstetric practices across the state and then working with them on training how to implement the AIM bundle, which is the Prism model.
Mhm. Well, I think I will need to understand that better, exactly what's the role of those clinics, because we might have clinic who are interested to be participating with one of your 8 clinics, but I need to explain to them exactly what's the benefit for them. I mean, what they're going to learn from that and all of that. So maybe I need a little bit more explanation for that.
Yeah, absolutely.
Not
Go ahead.
now.
Dr. Sorry.
Seems like half the patients will get Prism in a clinic and the other half will also get PSI in addition. It's a true implementation science project. And this is our PCORI funds, yeah.
So Sarah, just to be clear from the point of view of the consortium, the ask for the consortium isn't necessarily resources, et cetera, but that we would use the consult line as part of this and be in partnership with them through their funded PCORI grant. And so the request for our group is, if we need a motion that we participate with them on this initiative, or how would you frame the motion that you want us to look at today?
Yeah, I think that's a great way to frame it. Is there a motion for us to participate with Lifeline for Moms in implementation of in the training of the implementation of kind of the AIM bundles and the Prism?
With no additional resources from the consortium, except that those that have already been allocated for PeriPan?
Yes, if we were using, so there would be people who they were using their time during PeriPan potentially, but there's no request for funding for this.
Okay. Madhukar and then Stephen, Dr. Pliska, we'll go in that order.
I think, Sarah, Dr. Bakefield, this is exciting. I'll tell you, I've been a PI on 3 PCORI grants. It's pure implementation science, and they need places that will deliver it, and the mass group is asking you because they don't have it, and your PeriPan network is already getting national attention. So I don't know about all the EC decision, but I think it's a big credit to your program already.
Dr. Pliska?
Yeah, yes, I guess the question is, so are you asking, Sarah, we'll step forward to be a site for this, partnering with Lifeline, and they would come in and then we help them recruit OB practices to participate. And our faculty would be local co-PIs, so to speak. That's the model, right?
Yeah, so it's a good question about the co-PI model. I can't because I can get more data on that. But exactly what you originally said is that we would come in, so Lifeline would come in, they will do the consenting, the discussion, all of that with the obstetric practices. We would say, hey, these are some that we're aware of, that we know. I mean, because PeriPan is available to all obstetric practices in the state, then we would just need to, I mean, part of it would be that they were enrolled and willing to call PeriPan. I mean, that's part of it. And if they were enrolled and willing to call PeriPan, then the next step would be engaging that implementation of workflow. So how do they implement the AIM bundle, the newly recommended AIM bundle at their practice, and kind of going through that workflow with them, which one of the steps is calling the access project if someone screens in a certain way. And so then it would be our PeriPan psychiatrist being available for everything that they already are available for. And through this process, as many of our PeriPan psychiatrists and team members who can get trained, we were talking about potentially training, somebody at every HRI site in this implementation of PRISM. Then they would do it once and we would watch them. We would do it once and they would watch us. And then we would have the skill set to implement this wherever we would want to in the future.
But they would fund our local people to participate in this to the degree that they are participating, right?
Yes.
Right.
So just a comment, it's a site PI probably, not co-PI, because co-PI is network wide, but each clinic probably will have designated site PI, right?
Yes, and if we are willing to engage in this and want to do this, then they can. Dr. Byatt is more than happy to come and give a much larger, in depth, and then we'll talk with all of our sites too and identify who wants to participate through our PeriPan group and all of those things.
Maybe
Let me go to
the actual proposal so we can all look at it and get a little more, really get our teeth into it. My worry would be committing people to do additional things when we got so many people busy on all the current consortium projects and getting this going.
Yeah, Dr. Pliska, let me answer that for you, because one of the things is that we don't have to, the PeriPan, like the COSH PeriPan infrastructure can do all the training, can take on that role completely right now. And it wouldn't be on anybody else. My request of the group was, if there were other sites that wanted to get trained, could they get trained at the very beginning? And it would only be done with the time of the PeriPan psychiatrist that's already allocated, when they're allocated to be taking calls anyway.
Let me go to Cheryl, and then I'm going to kind of wrap this up just a little bit. So Cheryl, let me go to you, Dr. McCollum-Smith.
Yep. Hi. So I think this sounds great, Dr. Wakefield, and I would like to motion that we partner with PRISMs, provided it's not violating any of our funding regulations, because I think it sounds like a really critical, important part. And so I don't know exactly what I'm making the motion for, David, but make a motion that can we just say investigate this partnership or engage in this partnership, or?
I think that may be where we need to be, because just kind of reading some faces and comments, I think some people would like a little bit more information. And so maybe Sarah, if we could put on paper some of those details about really what that obligation is, commitment, et cetera. I hear support to investigate. I'm hearing support to learn more. Maybe have a continued conversation even with Dr. Byatt here. But I do get a sense from some members that they would like to make sure they know all the details before they make a commitment. And so could we put on paper, and then we'll bring that to this committee with a specific motion at our next meeting for formal approval. But in the meantime, continue to explore and get more information. Would that be a reasonable path forward, Sarah?
It is a reasonable path forward. I'm not able to attend the next committee meeting. I just wanted to make sure I'm clear on what we need to do. And we have to have an answer to them before March 1st. If we want to participate. So I have recorded the entire, the presentation that Dr. Byatt did to me. And if it would be helpful, I'm happy to have that sent out. I sent it to you, Dr. Lakey, and to Luann. I'm happy to send it out, if that would be something that would be helpful for the executive committee to hear.
I think that might be, but I think what they'll want is I mean, if there's a one pager that shows the commitment, what their obligations, listing what will be expected of them in this partnership, I think that would be helpful to
And
them.
specific aim, if possible. Just the first page of the grant, which says specific aims, what's the question, what's the structure? That's that it will already funded, so.
I think a lot of people would be very interested. They would just want some more details in a quick way that they can look through them. Is that doable?
Absolutely. We have the entire slide set that Dr. Byatt sent. And so I just included the highlights on here. And so we can send that out because that has all of the different aims. It has the reasoning for what to do. And we can discuss that. But just also want you to know that there's no specific ask of any HRI here. It's really more of the overall program to help with implementation, which would likely happen at the COSH level, and then to be available for those phone calls.
Dr. Lakey, as an aside to Dr. Wakefield's comment, the next consortium meeting is scheduled on federal holiday.
Okay. We'll take a look at that. All right, Dr. Trivedi?
I think one way to think about this would be any clinic, Dr. Pliska, that looks at it and understands the nuances, does not want to do it, doesn't have to do it. So therefore, a tentative approval, I'm not on the EC, so I don't have to vote. A tentative approval that says if clinics can be approached is all that Dr. Wakefield is asking. And then the clinics have the right to decide. They can say no, and
Dr. Trivedi, I think there is support in this, but I am sensing from several members that they would just like to know more before they give formal approval on actually what that commitment is. I think if we can send that out, we can actually maybe do it in other ways to get a formal vote, but they just would like to know what their obligations, what their responsibilities are or not. I think partnering with AIM, I know AIM is a good program. It's an important program for the state to try to drive up maternal health and birth outcomes here in the state of Texas. And so, the more we can help that to be successful, I think that would be good. So I don't think it has to be drawn out, but I'm getting the sense from several members that they would just like some of that additional information before they give it their formal approval.
Dr. Lakey, could I hear, because I hear that Dr. Librazon wants the AIM page, and I could pull that up right now and send it. But I don't think it'll say much more than what I've already said, but I'm happy to give that. If I can better understand what the questions are, because again, there's no specific request of any HRI right now. It would be if you were interested in being a part of the training so that your HRI would know that, what that training is, then we could do that. It would be on PeriPan time. I just want to make sure I'm aware of what if there are specific questions, I want to make sure I'm answering those and any information that's sent out. So if I could get some specific questions, that would be great.
Anybody, I guess we could gather that and maybe send it to you. That just cost of, just watching time. If anybody has questions besides those that they've raised, I think it's mostly going to be centered on what your expectations of them are. And Dr. Librazon wants to make sure he understands the exact aims, that he feels comfortable with us jumping in. And again, I think overall, the AIM bundles have been very important for Texas in moving quality improvement related to care for women and babies has been good. And so if there's a way to support that, it'd be great. Again, getting the sense from some members, they would just like to have on paper what their obligation is and is not before they give an approval. Israel, is that fair?
Absolutely. I think that what's important is that if we, for example, I do want to make sure that we have a large practice clinic that maybe will be really benefit. We're working together. They trust our recommendations. I just want to be able to come to them and coherently explain what are they going to meet what in general, and then they will can have into to have a more detailed discussion with the project stuff and so on. So for me to be able to coherently present it to my clinics and recommend, and they will probably listen to recommendation because we have a good relationship and so on, but that also requires me to be able to articulate it to them in a meaningful way. What's scientific value, what's the clinical value, and what's going on. So that's all. I think that's a reasonable kind of a expectation.
Dr. Liverstone, I think that's absolutely reasonable. I do want to suggest that that will be a part of the planning process, that there's no expectation that before March or even in the next couple of months that any of us would present this to a clinic to participate, but that there would be multiple meetings with Lifeline for Moms to better understand, you know, to get all of that data and then, or all of that information. And then there would be a coherent presentation to the clinics, and that would be part of the planning phase of that first year.
Got it. Cheryl, I see your hand. Give another comment?
Well, somewhat. The main thing that I would be concerned about is just overlap in the scope, and it doesn't sound like there's an overlap in scope, but just in terms of the funding. So I was just thinking about this issue, Sarah, about I'm applying for a HRSA grant that some of it tag teams onto some of the things we're doing. And do we have a document talking about aligning grants and like, so we can, because we want to keep piggybacking on other grants, right, as we go. That's one of our aims, right? We talked about that before with other types of grants, and this sounds ideal, right? So if we had a formal document that was just a simple form that we could go through, then we wouldn't have to go through this every time. So maybe this discussion could bring forward some simple checklist of things, you know, resource allocation, financial obligations, time. Are we double dipping anywhere? Does that make sense? Because otherwise, like, we want to be promoting this type of thing, right? And expanding our scope.
Yes, I think definitely we're trying to bring in additional awards and expand the scope of research in the state of Texas. Again, I just think Israel's wanting to jump in. So Israel.
A small comment. You're absolutely right, Cheryl, because although it's all what you are responding to exactly what Sarah was talking when she said, okay, the time is already paid by PeriPen. So PeriPen is a state funded or project, if I remember well. It's not ARPA, right? So then we need to understand when my person that I'm appointing to PeriPen, how much of their effort will be, for example, allocated to that thing and how appropriate to account for that. Do I understand, Cheryl, what you're saying correctly?
Yeah, so and it seems like we could have a simple form that we could fill out and just review, because I have a feeling we're going to be having a lot more of these piggyback or connected grants coming on. So rather than trying to reinvent this every time, I just think it would be useful to come up with, while we're thinking about this, maybe come up with what the criteria are, you know?
All right. Dr. Trivedi, and then I'm going to wrap up this part of the conversation.
I think that so I think the ask, if I can understand it correctly, which I think I do because I understand the chorus thing. These are clinics that Dr. Wakefield is talking about actually are in the public domain. This is a state-funded project. It's out there. The Massachusetts group could directly call them and say, do you want to participate? And they say yes, no, maybe. And all the efforts, Israel, that the research project the need from the clinic will be funded by the research project, not by PeriPen. All that this, I think, is happening is these Massachusetts guys are going to Dr. Wakefield because she's the lead on that, to say, can you help facilitate? She could say no, and still they have the right to go to these clinics. So I think, it's a win-win. So sorry, but because I understand exactly what Cheryl is saying. These requests, because we now have several of these networks that are vibrant and unlike anywhere in the country are going to be ripe places where people are coming to. And I think Dr. Wakefield is actually ahead of all of us. So that's
Dr. Trivedi, I appreciate that. And I do want to answer all of the questions. You are correct that the majority of the funding in this project goes to the clinic practices, would never come to PeriPan, is not doing anything for PeriPan. There is some potential funding for hiring like a specific coordinator to just focus on the clinics and the implementation of these practices and kind of coordinating that part of it. And so that was the idea. So PCORI is focused on implementation. The idea is trying to help us implement PeriPan even better than what we've done in a way that's worked in other states, specifically Massachusetts, utilizing AIM bundles, which we know are standard of care. So I do think this is a win-win for all of us. I am happy to answer any questions. Dr. Byatt's happy to come talk to us. If we just say, yes, we want to do this, then there will be many, many more opportunities to gather lots of information on this project. But I do want to make sure everyone's questions are, what we need answered so that we can say, yes, we want to do this, because I do believe it makes perfect sense for our state. And that's why I just asked what the specific questions might be.
So let's, Dr. Trivedi, I'm going to wind up this part of the conversation just so we can stay on time. And so what we're going to do, I think, Sarah, going ahead to explore, talking to her, finding out more details. I don't see anybody that has any reservations about that. We will ask everyone in the consortium, if you have questions about this, please send them to Luann, and Luann will send them out to Dr. Wakefield. I do think people will want to have some of those details. Again, I would focus on what obligations, what resources, et cetera, would be involved in this. But I think that can be a quick discussion and approval at next meeting. Sarah, even if you're not here, I think we can move that forward. But I'll give everyone a chance to ask their questions and get them answered before they vote. Is that fair, everyone?
Yeah.
All right. Very good. We're going to take a break at this point. Lunch is here. Why don't we resume at 12:45, and then we will continue. We have, I think, probably a little over an hour's worth of business after that. But again, I'm going to make sure we get done on time. But let's take a break, and we will resume at 12:45. Thank you. Bye. Well, welcome everyone. It is a little after 12:45. I need a couple people that I know here in the building to come back and join us, but we'll start in just a minute. Let me take a head count to make sure we're at quorum, and then we will get started. All right, I have a head count of 24. And again, there'll be a couple other people joining us, but I think we can go ahead and start and make sure we stay on time. The first item that we have is the statewide expansion report for TChat that we put together on a monthly basis. And why don't we go ahead and start with that?
Good afternoon, everyone. This is our expansion report with data as of the end of November. So you can see that we are active in just under 6,100 schools, representing about 65% of all schools in Texas. That also equals 70% of the student population covered. When we account for the schools that are onboarding and pending MOU, that should bring us to just about 65% of all schools. So we are getting very, very close to reaching that goal of being in every school that wants us.
We're covering 3.8 million kids across the state of Texas. 70% of the student population in Texas right now have TChat available to them in the school, and about 75% have either through TChat or other telehealth or in-person mental health services now available to them.
Yep.
Right. And again, congratulations to the progress on this chart. Several months ago, many of those were in the pending or onboarding status. And again, a lot of work has taken place to move them either fully having TChat or characterizing them appropriately. And so those gray boxes and those salmon boxes are becoming much, much smaller, and we're kind of approaching kind of the next phase. Thanks. Yes.
I know Rachel's not finished yet, but I just wanted to say, if you look at this big picture, this is really impressive. And I've had the opportunity to talk to lots of different audiences who are very interested in TChat and what we're doing. And what I want all of you to know is that inevitably there are certain times when I give presentations that families who have accessed TChat are participating as well on these conversations. And they have such positive things to say about the work that you all are doing. And so I just wanted to let you guys know that you are so appreciated across the state. Families just really are feeling like you are providing a service that they may not have had access to. And they feel very positive about that. And I've heard from a lot of school personnel as well how much they appreciate all of you. So I would be remiss if I didn't say that as part of this presentation. So thank you.
We have about 345 schools with onboarding status, and of those 75 with planned implementation dates. You can see that over the next number of months, most of those are occurring this month in January, with a few others occurring in the spring, and then Dell has some coming on board in the summer. Looking at our progress from an ESC perspective, 17 of our 20 ESC regions have now reached the over 50% mark, 50 or above. So we're making really good progress in every region across the state just in terms of getting those schools active. And then here you can see our growth over time continues at a good steady rate. And for the districts that have declined, you can see on the top right that most have declined because they have existing mental health providers, followed by just under 30% that have declined just some of the schools in their district.
All right. Any questions for Rochelle? Or Lachelle, Rachel and Lachelle. I just kind of combined your name, sorry. Rachel and Lachelle about the data. All right, I don't hear any questions. Again, I think it's good, steady progress. And again, those lines are pretty straight related to the number of new schools being added each month. And so we're approaching kind of the finishing of this phase of getting all the schools enrolled. And as part of our conversations now is kind of the next phase of how then we continue on quality improvement and wrap in the projects that were through ARPA and kind of what the next phase of this overall TChat looks like. Kind of what we're talking about in our office, kind of TChat 2.0, kind of the next version of TChat now that we've completed. We're getting near the completion of this big phase of getting it built into all the schools that want it. All right, I don't see any other questions. So again, thank you. And Dr. Williams, Laurel, let me go to you.
Hopefully it's not too stormy where you are. It's definitely kind of a gray and cloudy day here in Houston. Welcome. Thank you for getting my slides. And I know we don't have snow anymore, but it was brief excitement at my house that there might be something, and then that's kind of what it looked like. All right. Next slide. So we're talking about CPAN first. Next slide. We're going to go over the topics today. Let me just start off with, I don't think I'll be more than 15 minutes, probably over total, but for CPAN specifically, we'll be talking about our resource database, things that we're doing with our information technology team trait with their releases and roadmap, the overall call volume, and then some specific just information related to some new processes within our sort of collecting data. So we can sort of look at sort of an example of that and then some conversations around that. Next slide. So the update is that the contract for sort of the WellNeti system has been finally gotten through all of its necessary spots. It's been about a year and change that the work groups were coordinating with Edith and Lachelle to talk through how to make several improvements to the database process. And so that itself has almost wrapped up. There's still a little bit back and forth with the work group on a few things. I'm hoping that that will get itself fully wrapped up. And then the goal is that the sort of refined WellNeti will be available, completed for our teams for CPAN and then eventually TChat as well in April of 2024. So it was a reasonable amount of work that the work groups did across the state. Each HRI was participating. Edith and Lachelle were sort of organizing it. And we had a lot of back and forth with the WellNeti team so that we're really hoping that we've developed some processes that will make it more efficient for our teams to sort of work within the database and to make sure that we're always giving. Our goal is to always give a primary care provider the most up-to-date resources available. Our team will cross-check to make sure that any resource that we hand over to them, we call, we confirm that they're available. They take the person's insurance, they have when is their next available. Those types of things are reviewed every time we hand out things. And WellNeti will keep that information up to date, so we're not, looking for resources that are not actually able to help families. So that's one of our charges within CPAN and TChat. So we're excited for that. Next slide. Again, we have several improvements that have already been completed. One of them I'm going to talk about today is around the specifically medications, but a lot of, we had work groups that were created over the summer, fall. They finished their work, was approved through all the various mechanisms, and we made several enhancements to make the sort of process of having the CPAN consultation go as smoothly as it can possibly go, not just for our clinicians, but also for the physicians, providers when they call in, and also for us to collect data. So we're happy for those improvements to the portal. We also have additional exports that are available for our team, so it can help them with some of the outreach efforts they're doing, also quality improvements, any things that they would want to do to kind of help their team. And then also specifically, again, this new medication export that's available to us to allow us to really understand sort of not just, you know, what we're doing with, you know, making recommendations related to resources, but also how we're helping provide education to primary care providers when it comes to considering psychotropic medications. Next slide. So you can see here, there's additional roadmap items available. Most of these things we're hoping to be done within Q2. As you can see, some of them are in design, so they won't be available Q1, but more likely Q2. And then there's a few things that we're considering doing and working with the internal evaluation team as it relates to, again, trying to synthesize and make things run slightly more efficiently, and that some of the surveys, or not some of the surveys that the internal evaluation team wants to sort of put in front of providers for them to sort of say how they view the program, that would be something that would go out through the trait system. So we're defining those requirements, and we'll have a better sense of release date once we get those design requirements sort of in. Next slide. So we just wanted to do, as we've been doing recently, sort of give you that sort of comparison between this year and last year when it comes to overall consultation volume. One of the things I do want to be clear about is this slide does not include the number of direct consultations we've done. You can see that down at the very teeny tiny with the asterisk. My eyeballs can see it. So the lines are about the consultation calls that are the telephone where we, you know, our team members speak to the physician or provider and provide advice in real time in the call. We also have been doing direct consultations, and as you can see there below at the bottom, it's 344 direct consultations have been completed since we started that project through the ARPA process. We continue to see growth within CPAN, and we continue to see, as you're going to see with the TChat numbers as well, by the way, that sort of seasonal variation related to sort of call volume and referral volume when we're looking at TChat in a minute. But overall, we are continuing to see growth within our team and continue to have a lot of repeat customers, a lot of satisfaction from the physicians and other providers who utilize the CPAN service. Next slide. One of the things, though, that we are really wanting to focus on in the next 2 quarters is really to make sure that we're fully engaging and utilizing all of our team members, and particularly our physicians. So we are going to be rolling out a number of strategies and tactics to kind of increase that work that our teams can do. So when Dr. Wakefield's on CPAN, for example, or Dr. Martin's on CPAN, for example, CPAN-PeriPAN, excuse me, then there'll be things that they'll be doing during their time that they are slated to be doing. So these are not activities that they're going to be doing outside of their time. These are going to be activities that they're going to be doing. We've gotten a lot of feedback from our experts within communications with Melanie Susswine and her team, and also our MCPAP and Lifeline for Moms teams about how really using our physicians to our full effect to have a physician-to-physician conversation to really help engage those primary care physicians who have enrolled in the service but have not yet started to use the service. So we are going to be doing a number of those strategies, as you see here up here, including the one that we've been wanting to do for a while. I'm going to go down to the bottom where the CPAN TChat connection. One of the things that we've always wanted to do is make sure that we're not coordinated within our own programming. So whenever we have patients and young people and families being seen via TChat, particularly with physician involved care, we want to make sure that those primary care physicians are really involved and understand that patients that they see in their pediatric or family medicine clinics know that they're getting TChat services. And because a lot of the TChat services that involve physicians, involve ADHD treatments and depression treatments. Those are both things that AAP has recommended are things that first-line primary care physicians should be knowledgeable about and hopefully should be able to provide treatment. So we're hoping that we can make a tighter connection with that and try to get more of those primary care physicians to sort of take on the care of TCHAT that's around those sort of issues once TCHAT care is over. So that's one thing we're very excited about. But again, a number of the strategies in the next 2 quarters are really around how to sort of increase the engagement of our providers to our provider colleagues, the pediatricians, the family docs, the OBs, and have that people that are enrolled but have not yet started to utilize the service more and more. Next slide. So one of the things that we did was sort of our improvements with our database is that we're now able to kind of look more specifically related to medications. We made a number of improvements. And again, this was work that was done with collaborations with the evaluation teams, with the UT system teams, with the HRIs themselves. So all these things were sort of pulled together. And when you see here in the last, just December of itself, you can see that, again, the top 3 reasons for why a primary care physician is calling and asking for help related to CPAN is related to ADHD treatments, anxiety treatments, and depression and sadness. Again, these are all straight within their wheelhouse and things that we want to help them become more comfortable with, more knowledgeable about, more skilled at, so they themselves can provide that care when appropriate within their own systems versus making a referral out to a psychiatrist, for example. But again, you can see that we have now been able to very cleanly connect the dots between if there was a medication recommendation, what was the reason for that medication recommendation. Next slide. And this slide, I wanted to just do a very brief kind of deep dive into one of the things that we can do, get very specific. And we're going to be forming a work group that will again include the HRIs, the internal evaluation team, to kind of think through what would we like to see regularly from a reporting perspective related to our recommendations specifically around medications. Again, some of these things can be QI for our own self. It could also help us decide what kinds of additional CME activities we might want to provide to physicians, or any materials that we want to be able to create and connect the dots for those primary care physicians. As you can see here at the very bottom, we are looking at sort of antipsychotic medications in relation to the total number. So blue is total number of medication recommendations that were made in December of 2023 by our CPAN physicians. And so when you see here, there's 176 total recommendations to add a medication. But when you added the medication, you can very specifically look at the class of medication that was added. So out of the 176, 16 times was there a recommendation to add an antipsychotic. And then you can see for the continue, there was 67 recommendations to continue treat a medication. And of those 67, 8 of them were to continue an antipsychotic. And you can see here, as you go down, 47 for stop. Of those, 5 were antipsychotics, so forth and so on. So we can get down to the very specific level, the actual type of medication within that class. So we can look at things from both a class perspective as well as specific medication, and also even dose ranges, and be connecting the dots between those medications and the reasons for why those recommendations, because there needs to either be a diagnosis or a symptom that is being targeted in order to make the recommendation for the medication. So this is just a very quick review of what this sort of additional layer of data will be able to provide us. And like I said, we're going to develop a work group to think through what kind of reporting do we want to have on this, as well as what will we use that data for to help. And again, my primary goal is to help us with QI, but also to kind of explain more about what the CPAN services provided do, as well as further down the road, CME activities that we want to focus on. Next slide. And then this slide was just, again, one of the things that we made improvements with the platform was that there was a request from the physicians in CPAN, PeriPAN, that sometimes they didn't want, it wasn't clinically appropriate to make a specific recommendation for a medication, but it would be more appropriate to make a general class recommendation and then talk through the pros and cons of particular classes of medications in relation to a diagnosis or a symptom. So the physicians wanted to have the ability to discriminate between when they make a specific recommendation versus when they make a general recommendation. So you can see here in the month of December only, it was definitely way more common for our CPAN providers to make something very specific from a recommendation perspective versus general. But we'll continue to track that. And again, one of the things that we can do is see, over time, what are the sort of characteristics that make us do a general recommendation versus specific and vice versa. So it'll just be another way for us to have more specificity in sort of the data. So I just wanted to point that out for us. Next slide. So that's CPAN. The summit is happening, so we certainly hope to see a lot of the smiling faces. I do want to thank the UT system, Monet, Lachelle, Sarah, Rachel, Nagla. Oh my goodness, probably missing somebody, and our own team, because they've put a lot of effort and work into having the summit kind of come together. We're going to have two national experts, Dr. Barry Sarvet, who's come and presented to us before and helped us with our implementation of CPAN, and also Nancy Byatt are coming. We also have providers across the state coming as the end user to give us their feedback. So we really are really excited to have the summit next month, or next week, not next month, next week. So yay. Okay, TCHAT. Next slide. So I did ask for Jen to do this slide a little bit differently. It's just a little bit more like how I think from year to year versus totals over cumulative. So this is maybe a little bit of a different orientation. But essentially what you see is these stack lines are each the last 3 years of referrals. This is not care delivered at this point. This is just the number of referrals that the TCHAT program has got in. We do anticipate that as Molly and her team start to kind of gear up with their new team members, and we coordinate with them towards the end of the school year, there'll be some additional information that will get provided to the executive committee related to actual care delivered. But this is right now just the known universe of referrals. So as you hopefully can see from this graph, as we continue to partner with schools, as Rachel said earlier, and Dr. Lakey and Luann pointed out, and they get to know us and they see the value of the program, as well as we additionally continue to get new school districts and campuses onboarded. The number of referrals from month to month over time are definitely going up quite considerably. So as again, just like with CPAN, you see this seasonal variation with referral patterns for consultation in CPAN and in TCHAT. So kids are often needing more help in the sort of middle of each of the semesters of school, and that sort of bears out with this data. And we had, once again, another sort of first for our TCHAT program with the number of referrals in any given month for the month of October. So the number down below, that 52, is all referrals, including referrals that came before Trait was collecting the data. And once again, it's a significant number of referrals across the state that the program is getting, and we will have more data related to care delivery in the next couple of months. Next slide. So again, there's a lot of work that all the teams have been doing. I just want to thank them all. You've got great teams across each of the HRIs. They're working just tirelessly all the time in both CPAN and TCHAT. But within their just regular sort of quote day job for CPAN and TCHAT, they're also being asked to step in and be involved in work groups so that we can work to make process improvements, talk about where things can be, when things are similar enough that we can sort of say it's a policy or a process that all the HRIs are going to follow. So all those things are coming together in a very collaborative way. So we've been leading work groups, as I've said. Recommendations are currently being reviewed by leadership, and as needed, they'll get taken up through executive committee. We've been collaborating with the UT systems related to the TCHAT newsletter and CPAN newsletter that's now going out to all the team members across the state, as well as things that we're doing to coordinate and collaborate with TEA. We do have the team from Massachusetts here today, and we've been planning with that visit. They're in Austin today, and I think Summit tomorrow, and then they're going to be in Houston on Wednesday. And both UTMB, not both, all three, UTMB, UT Houston, and Baylor are going to meet with the Massachusetts team on Wednesday to kind of talk about TCHAT and answer any questions that they have. We've also been working on preparing, helping Lainey and her team related to how we're kind of Lainey's team's done all the work in collecting the information from all the HRIs about the communications that we do via T-Chat and working to sort of, again, streamline and centralize as appropriate some of those communications. And we're obviously been working very closely with all the HRIs in the UT system around this sort of idea of T-Chat 2.0. And then, of course, anytime there's specific things that teams need within our sort of monthly meetings, we're doing that as well. So a lot of work is going on within T-Chat. Next slide. So I said we provide that one-on-one support. We've had a couple of teams in the fall who needed to sort of have some of their students possibly kind of get connected to care with some of our other HRIs. And so we continue to work on that process to sort of be run in a statewide way so that if anybody has sort of has referrals that they need help with, another team is possibly stepping in. We are helping support staff training and as well as all the data pulls that are necessary. Next slide. Again, within the trait system, we have several initiatives. We do now have CIS automation, so that functional impairment scale that parents and children are being asked to do at the beginning of their delivery of care with T-Chat, and now it's automated to do when they are now in T-Chat, so that we don't have to have anybody remembering, oh, this is the second visit, this is the third visit. Now that's an automated process. We did also, with that companion with CPAN medication upgrades, we did similar things with medication tracking and data capture for T-Chat. Also, it was related to, again, automating several of the things to kind of make processes run more efficiently. In order to do that, obviously, we need to collaborate and coordinate with the HRIs to make sure that it sort of falls in line with sort of the processes that they do operationally. And so that's a big lift to kind of get teams to coordinate in that way and sort of have processes be similar enough that you can do some of this automation. So we're excited for those initiatives. Next slide. So I just want to, again, this is a brief, this is not, to Dr. Newpoint's earlier, this is not an analysis, this is just a data poll to sort of provide some initial information. And then again, we're going to have a work group pulled together for T-Chat specifically as well to kind of look at how we're going to sort of review this data and what we're going to use this data for to help us with QI. But when you see here in the month of December was that there was 453 patients across the state of Texas that were seen by a psychiatrist or NP in December. And of those 453 patients, 357 of them had a prescribed medication through T-Chat. And you can see over here the diagnoses related. So once again, this is every medication that's being recommended will have an associated reason for why it's being recommended. And as I said with the CPAN T-Chat connection just maybe 3 minutes ago, the biggest number of reasons for why our child psychiatrist or NP folks are being asked to help families in Texas relates to anxiety, ADHD, and depression. So again, these are very much within the wheelhouse of primary care physicians. And so what we're hoping is that our T-Chat psychiatrists can hopefully see the child, see the family, come up with a sort of a good treatment of care, recommended care plan, maybe start the care plan, but then hopefully we can use CPAN to start to transition some of those cases that are mild to moderate, don't really need to sit within a psychiatry specialty clinic's office, and get them maybe to be connected to those who do have a primary care physician, get them connected with their primary care physician, therefore allowing us to continue to be delivering our T-Chat services, which we consider to be, quick access to care, right? So again, this is just the known universe of the diagnoses. Next slide. And then very specifically, we wanted to sort of say you can now drill down even to the HRI level. And so again, we just wanted to see within one specific HRI that within that HRI, 35 patients were seen by psychiatry in the month of December. Of those 35, 25 of the patients were prescribed a medication through T-Chat. And once again, the sort of largest reasons for why we're prescribing the medication within that HRI related to actually to ADHD. And so again, because T-Chat is meant to be maybe for kids who've never even gotten a service yet, it hasn't had diagnosis clarified, this can really be life-changing for them and the family to kind of get into treatment and get care going. Particularly for ADHD, you can have a pretty quick turnaround and sort of helping that young person. But as you can see here, those were the diagnoses that were related to the medications. And then very specifically, again, we can drill down to not just the diagnosis, but also the specific medications. And as you can see here, 6 patients received a very specific medication that's for ADHD and the dose range, and that it was prescribed for the purpose of ADHD. So this is the kind of level of specificity that our team is now going to be able to have available to us. Each HRI has the medication export available to them, so they could look at their own HRI level. As I said, we're going to take this as a statewide work group to talk through what would be sort of regular reports that we may want to have available to our teams beyond just looking at the raw data. So exciting sort of addition that I know a couple of you guys have been waiting for a bit of time for. Next slide. Ta-da! I told you about 15 minutes, so happy to take any questions if needed.
Very good. Any questions for Dr. Williams? Dr. Trivedi?
Your CPAM data is exciting because it sounds like you're obviously recommending medication changes and all that, but like a large proportion, you're actually recommending decreases. There is a whole debate in the field, as you well better know, you and Dr. Wakefield and Wagner know, about both sides happening, under treatment and over treatment. So are there publications you're working on with that? I mean, it'll be helpful for the field to understand that there's a group of people who are getting too much and we need to do something, right? I mean, it's exciting data you showed.
I would definitely want to do that. So this level of specificity just went online this fall. And so I do think that as the data set matures, that would be one of the activities we'd want. And so welcome your input there.
Happy to help anyway, because I think that creates that, yeah, you know this better than I do, but I think it creates this whole sense that we are getting too much medication, which is true for some, and yet you're recommending more medications for others. And I think putting that out in the public domain, it would be wonderful. So great work. Thank you.
We're pretty excited.
And Laurel, I think the other part of that story is with TCHAT that most of the kids don't end up seeing the psychiatrist or getting put on medicines. That the vast majority is with counselors and therapy and having somebody to talk to, and that's resolving the vast majority of the challenges that are sitting our way. Is that correct? Anything you want to add to that?
That is correct. So when you look at December, we looked around 3,000 encounters were to see a therapist. So again, about 10% of the total volume of care being delivered is related to sort of psychiatric assessments and or treatments as needed. And so yes, the vast majority of care is, because again, for most kids, the evidence-based treatment is a psychotherapy for most of the disorders, first line.
And Laura, it looked to me, you had the number of referrals in October hitting 3,500. It looked like to me, looking at some other data, that the number of sessions, we almost hit 9,000 sessions at the end of the year in 1 month. So an incredible volume spread across all your institutions.
There's a ton of volume.
Incredible data. I'm happy to help in any way, Laurel, because I think I put it out because I think this has the potential to change practice.
I think that one of the things I was going to say, just to respond, Dr. Trivedi, one of the things that we are very interested in is some of the work that you're doing in the trauma and the depression networks related to resilience factors. You know, a lot of our teams are wanting to understand, you know, can we gather some information in a non-burdensome way to sort of categorize children and then make the most appropriate recommendation and get them to the care level that they need as quickly as possible. Obviously, many people have been working after this sort of nirvana for a long time, but I think that the work that the teams are doing within trauma and the depression network are very much meaningful and applicable to sort of us to be thinking about for TCHAT.
Let me go to Dr. Wakefield, and then I'll go to Olga Rodriguez.
Yeah, I think we're all, I'm probably going to say something that's similar to what we're all kind of already saying already, but I would be very interested, first of all, that 10% seeing or related to medication, I wonder is that reflective of we're not seeing, I'm thinking through Dr. Trivedi, like when our recommendations are for severe depression, maybe doing both depression, medication and therapy, looking at the rates and really kind of drilling down on, I agree with you, Dr. Williams. Obviously, the majority of the recommendations for different types of interventions for kiddos are therapeutic. And that's really important that they're getting those types of interventions. But then thinking through some of the more severe symptom presentations, and are we utilizing measurement-based care in a way that we can say, hey, if a kiddo is, mild to moderate, they're funneled to a therapeutic intervention that doesn't involve a medication as a first line, and developing a stepped care model where we're not waiting to see, we're not waiting too long before we intervene in a collaborative way, so that we can get kids fast, quicker, better, as quickly as possible. I'm having trouble word finding, and so really looking at, with this opportunity or with this data, the opportunity to really hone in on that stepped care model so that we're not providing medication to kiddos who don't need it, but we're not delaying care for kids who are going to need it when we know we have good data about who might need those things, and working with, not just the data that we're finding in YDSRN and then Trauma Network, but data that we're already aware of, or, putting kids in that model. Because 10% seems low to me. It may be because I live in such an under-resourced area that so many of our kiddos don't have access to treatment until they're so severe that they're requiring more intervention. And so that just may be my experience. But when we launched our school-based program in 2013, we started with psychiatry. And so everybody got psychiatry, and we quickly learned that we definitely needed therapy in there. But that 10% is very, it's just intriguing to me because it seems low for the subset of kids that we're asked to see.
But that is also the network richness that could be a good platform for somebody in this group or others writing a PCORI grant. They want to know, they want to fund it because because the field doesn't know how to deal with it. So exactly, like your Peripan grant, yeah.
Absolutely. I think the step care model, that several teams are currently employing is primarily a model of stepping up or stepping away from psychotherapy. And I think that there is, again, when you started talking about what are the algorithms, particularly for moderate to severe depression and anxiety, they're usually a recommendation to do both things simultaneously versus one at a time. So I think that we have a lot of opportunities here where we can sort of really use data to help us. And again, TCHAT as a group, I think TCHAT 2.0 is going to be reviewed at the next executive committee meeting, but this sort of idea of using measurement-based care is sort of our piece of that, so that we are kind of able to say, within that first assessment, what is the severity level, and then use that information for the therapist and the family, or the provider and the family, to kind of think through what would be really the evidence-based approach for your child based on this information, and really partnering with families. Because again, we always want to, make sure that parents have ultimate, abilities to say what do they feel comfortable with. And I know many times I may recommend a combined approach that a family says, well, I understand that, Dr. Williams, but I really prefer to try therapy first. I'm like, of course. So this is always about that partnership with families.
Yeah, one of the things the legislature might be very excited to buy is we get more peer-reviewed grants on this, right? And exactly the network you already have.
So I think, Laurel, having now the ability to look at medications and that kind of changes, I think this will be very helpful to us as we continue to tell the story of the work we're doing. So congratulations on getting that up for both CPAN and TCHAT. Olga, let me go to you.
So I'm just wondering what the committee thinks about the dip in summer and December. I mean, there's a lot of data, right, that shows actually that's when greater anxiety and greater depression happens during the summer and and the December months. And so is there another way or other partnerships that that can happen through the consortium? And for example, during the summer, do a lot of the kiddos enroll in YMCA programs? And do any of those YMCA programs have, you know, partnerships with the HRIs of any sort? So, because their problems don't just go away for the summer and Christmas break, right? And so are we possibly losing some kiddos during that time? Are we, you know, not making improvements as more improvements as we're thinking? Every time I look at that data, every time that summer and December really bothers me from a just public policy standpoint. Like how do we have a regular source, you know, for parents and families to lean on? So I didn't know if anyone had thoughts about that dip in the data. I know it's expected, but that doesn't mean it's okay.
Well, I will also just argue that we don't stop delivering care. So we continue to reach out to families, we continue to schedule appointments. So we don't stop delivering care in December in the summer months. And often because our referral base is growing and growing, you know, we are seeing care delivered over those time periods. What we actually find a lot of times is family themselves are like, well, we're out of town. We have this other activity that we're planning to do. And it's very common for us to have families say, no, we'll get back to you in January. We'll get back to you in August. So I don't disagree that there might be some additional partnerships. Happy to hear people discuss it. But I also didn't want to leave the impression that we're not providing care. We absolutely are open in those months, seeing kids and families.
Very good. Dr. Wakefield?
Yeah, I was just interested, Olga, if you could provide, I would love to review the sources, and maybe other people here see them, of anxiety increasing over the summer. I think we see this natural dip in our outpatient clinics as well, not just in our school referral patterns. So I do think that there's a component of kids not physically being in school and not being, you know, not having somebody else who will refer them, that there is a component there. But I also think, to Dr. Williams' point, that families often are engaged in different activities that don't trigger kids' anxiety in the same way and trigger some of their symptoms in the same way. And so even kids in care tend to say, well, I'm not, you know, I always say I will have kids not show up in the summer for appointments. And then, you know, everybody calls in September and October and says I'm in crisis. And I was like, well, I had this full availability to see you over the summer. And they were like, well, I wasn't in crisis then. I wasn't having symptoms then. And so I think it is, first, there's a lot of psychoeducation that goes to families around that these things don't totally disappear. Summer is a great time to work on skill sets and therapy so that they're not having to be out of school as much. But I'm not aware, I am aware of data of kids having, you know, when they're not in school, being more exposed to abuse and other things happening in the home, but not of actually like increasing anxiety symptoms. And so I'd love to review those data sources.
Okay, thank you.
All right. Any other questions, comments? Want to make sure we reflect in the record. I don't know if Dr. Chapa, if you were here when we did roll call earlier, but I see you and just want to make sure that we reflect that. And Andy Keller, good to see you. And I want to make sure that we reflect that. And Dr. Babato, also want to make sure we reflect that in the record. Anybody else that I didn't recognize earlier? Okay.
I was not important. No.
Yep, we got you. All right. All right. Well, Laurel, again, thank you for all the hard work on that. I really appreciate the monthly update. And as I noted earlier, I think now having the ability to drill down on the medications a little bit more than we could in the past is going to be very helpful as we tell the story. Let's transition now to the update on the ARPA funded initiatives. And first, Linda Haster, I think I saw you earlier to give the update from UT Austin as our fiscal agent on the ARPA dollars.
Linda had a last minute conflict, so I am stepping in for her. This is Joy Hatch.
Thanks, Joy. Good to have you here.
Hello. Yes, and you can go to the next slide. And also we will be rebranding the slides for the next meeting to match the branding. So the expenditures by program, the total of this is just over 31, approaching 31.5 million. So about 8.5 in CPAN, just over 18 million in TChat, and approaching 5 for CPWE. And the next two slides break this down by the initiative and by the HRI. So the money's being spent. There you can see by the HRIs. And then the next one shows by the program, also in reference to the budgeted amounts. So that is just our financial data at this time. And yeah, I think that's all I have at least. So feel free to ask questions or send your inquiries to Linda Haster, and we'll be happy to address those.
Good. Any questions for Joy?
I guess, are all the new contracts executed now? I know we had a little bit of a delay in that.
No, we are still actually waiting on ours to be fully executed before we can send out those extensions to the HRIs. So it's still in progress.
Yeah, because we're not able to obviously bill the programs at all.
Correct.
That's starting to drain our other state funds because we're obviously not going to lay the people off.
Correct.
So
We're in the same place. We're waiting on that signature, and we've got the agreements that we have. All of the agreements that we can are lined up and ready to go out the door as soon as we get those signatures.
And these people, why are they not signing it? Is there anything I can do? Can I give them a call?
I'm not sure about that.
All right. No, thanks, Joy, and thanks, Steve, for bringing that up. I think that's something that we can follow up on offline to make sure that that's moving forward. Okay.
Yeah, it also makes it hard to track expenses in different programs and you're going to move people back and forth. Yeah, so it's just, I understand bureaucracy, but this has been quite a few months now.
Okay. Thanks, Steve. Anything else? Hearing none, let's go to the update on the Youth Aware of Mental Health Initiative. Dr. Trivedi, you want to give the overview? Dr. Trivedi, are you? There you are.
Thank you. Okay, thank you. The project is now actually really taking off, so I'm very excited. And this year is calendar year, but also the academic year will be our big year. So next slide. I'll give you a sense of what we are doing. We have now trained 206 instructors over 14 sessions. Just as a perspective, guys, I have to tell you, we have actually trained more instructors than this country of Australia that is now using YAM across the entire country. So we now have had these repeated sessions. We've been very lucky in having a support and participation from all HRIs. And we now have 200 plus instructors trained over the whole state, which is exciting because they will actually, even if I stop and you guys all stop us from doing it, this will continue. So that is amazing work. And I appreciate all the HRIs doing the work on sending us people because we have a 5-day session and it's an imposition. It's a very rigorous training. It's a 5-day training. As if they are in the classroom, they are actually being trained as if they are in the classroom and to deliver the program. So they get hands-on experience themselves. And we have 200 plus people around the state. This is amazing. So I appreciate it. Next slide. We also have had the benefit of having MOUs with each school district And so we now have extensive school district MOUs across the state. And we now basically have across the state about 1 million people, 1 million students who are now exposed or at least have the access to this program. Next slide. We have been actually doing these programs. We have close to 23,559 kids already experiencing this program. And our goal is by the end of the school year, have 35,000 students already engaged in the program. It is available to the larger population. And I think the big question, and I love your input, Laurel and others, on how we marry this exactly closely with TChat, because I think you all have the connections and we are doing it independently. All of our HRIs are doing it independently, and it would be wonderful if we can actually marry it and incorporate it, because we have the interest and the support to do it even more. But we are actually going to get to 35,000 students by the end of this school year, which is amazing. So if you compare it again to Australia, we are doing profoundly better. Next slide. We have overall by region, you can see each of these regions. We have classes that are being addressed. So we have close to like 275 classes in Dallas area, and down to UTMB with 44, but these are classrooms that have achieved it. Next slide. And so our total students have spent about these number of hours participating in since the spring of 2022. This is actually wonderful, and I appreciate all the support from all the HRIs. I think this is, yeah, I'm going to stop, and next slide is questions if anybody has any.
All right. Any questions from the executive committee? Luann?
Hi, Dr. Trivedi. This is Luann. I wanted to ask the question. I get questions from school personnel about the ability for someone from the school campus to be trained on YAM. And so could you answer that? I know that we've got Julie Wayman here and Nathan and Dr. Scott. So just curious about that because there have been some questions about that.
Yes, so thank you. Luann always asks the right questions, right, David, Dr. Lakey? So the question is, can school staff be involved? And the point of the program is it is a stress-free, judgment-free program where you do not want your math teacher to be the person delivering the program, because then you have a conflict. So the program is designed to be delivered by people who are independent of the main people involved in the student's life. So to answer your direct question, Luann, yes, anybody who is not involved in their care or in their teaching can be trained. So like we just did something with Plano High School. So they have 4 high schools. So high school number 1, their staff can deliver it in high school number 2, not in high school number 1. So we'll just have to finagle that approach. I don't think there is anything preventing us from training school staff, but you don't want your mother to ask you what your mental health concerns are. You want somebody independent. That's the goal. So we just have to figure that out. But short answer is yes, school staff can be trained as long as they deliver that program in another school, not in their own students. Does that answer your question, Luann?
Thank you, Dr. Trivedi.
Because it's really an amazing program, but it depends on independence, privacy, and safety, right? So if you are my math teacher and I do this program with you, and you're asking me if my mother or father this or that, I think it will be conflicted and not real. So I got to do that program as a high schooler with somebody who's not my teacher. That's the only thing that we are trying to accomplish.
All right. Any other questions? Seeing none, thank you, Madhukar, for all your work on that. Let's go next to the update on the pediatric collaborative care work, and Dr. Talebi. Hani, good to see you. Let me turn it over to you.
Thanks, Dr. Legge. Appreciate it. Hi, everybody. Good to see you all. I think we've been throwing Happy New Year's out there, so a belated Happy New Year to everybody. I'll give a very brief update on our ARPA Pediatric Collaborative Care programming. Next slide, please. A little bit about what we've been doing since past August up until now. Ongoing, we have our one-on-one monthly meetings with our HRIs that are participating in this initiative, answering questions, talking about any barriers they're experiencing and how best we can support them in facilitating getting over those challenges. We have published, a lot of you already know about the Roundtable on Pediatric Collaborative Care, where we brought together thought leaders across the country who are engaged in pediatric collaborative care to better articulate best practices and be able to disseminate those, not just to engaged HRIs in this initiative, but also to push forward and disseminate that knowledge even further. And so we were able to publish that in a white paper format and get those proceedings out. We're always continuing to work with our partners. In September with the Primary Care Collaborative Behavioral Health Integration Work Group. In October, we were able to present in Washington, D.C. in the American Psychiatric Association's Mental Health Services Conference, in the Collaborative Family Healthcare Association's Conference in Phoenix, and then at the ACAP annual meeting in New York City, all related to the great work that our partners were all doing across this initiative. In the spirit of continuing to support our HRIs in recruiting health systems, we in November traveled to El Paso and coordinated with various partners to recruit different pediatric practices in the region and to get them a little bit more engaged and involved with our efforts. That was very successful, and we continue to move forward on that front. December, we held our individual HRI meetings and talked a little bit more about updated metrics and answering questions about implementations, various health system questions that have come up and have moved forward through January to our all HRI meeting that just took place last week. And the wonderful Dr. Farmer, as always, was very willing to jump in and talk about the successes and challenges that they have experienced. Really want this to be a learning collaborative. And so other HRIs and their reps were able to ask questions and talk about some of the similarities and differences that folks have been experiencing over time. Next slide, please. Coming up next, really thinking about how best we can continue to support forward progress. We have our monthly report submission coming up in February. We continue to update our cache of resources, reference guide for COCM trainings, including pediatric specific trainings, family systems oriented trainings, continued development of our inventory with respect to psychiatric consultancy vendors, and if our HRIs wanted to leverage that as an option, and then continued communication with HHSC and TCMHCC relative to FQHC and RHC billing strategies, knowing that those have yet to be approved in the state of Texas for pediatric collaborative care, but we keep knocking on that door. And hopefully we'll continue to make progress on that so that that lever gets pulled and pushed to the point where it moves that forward. Our main goals forthcoming end up being continued recruitment of health systems for HRIs, our monthly TA opportunities to ensure that HRIs and recruited health systems have the support that they need to move things forward, our required monthly metric reporting, and discussion and exploration of a pediatric collaborative care pediatrician focused work group. We oftentimes don't have those clinical champions involved in all the conversations, secondary to a number of reasons, primarily being a time bandwidth issues. So getting a lot of those folks in the same place at the same time to be able to talk about pediatric collaborative care and the benefits therein. Next slide, please. Thinking about our two primary metrics, really we're looking at initially reached, and health system commitments. On the former, our project goal in its entirety is 100,000 unique lives. We have achieved that obviously and surpassed it. That number will continue to increase. So we're feeling really positive about that accomplishment. Health system commitments, this one has been, we're on pace and doing really well, but to Dr. Plitzka's earlier comments, contract extensions and those updates have somewhat stymied our efforts on this front. But again, we know that UT Austin and our other partners are working very, very hard to move these things forward, and not a trivial matter getting all of that managed. So we're looking forward in the next few months here to really see that health system commitment number increase and reach that metric goal. Next slide, please. That's all I have to report for today. Happy to field any questions you might have.
Very good. Any questions for Hani? Dr. Trivedi?
So this is actually an amazing program that no other state is doing. I think, Hani, maybe start thinking about publishing this. I don't know any other state that's done this. And I think you have a whole lot of health systems that are actually agreeing to do this. Because everybody knows collaborative care works, but nobody uses it. And I think you're making it happen. So my compliments to you.
Thanks, Madhukar. Appreciate that. Yeah, I think as other folks have mentioned too, I think the collaborative care is obviously a rigorous evidence base there for kind of adult populations. But looking at the ped side of things, I think we have a unique opportunity to really be able to push these things forward and highlight the great work graciously funded through the consortium and the ledge, but being able to push that forward and show folks how we're really innovating in Texas and being able to show that force multiplication and scaling it is a good idea. So let's keep talking about that one.
Yeah, because you and Andy have enticed these people to do it, and a lot of states want to do it. Like I was telling you, I was on the peer review committee for the California group, and they are struggling. I don't think they have succeeded as much as you have. So you gotta somehow advertise it.
Dr. Keller? Andy, I saw your hand. I'm taking that as a no that you've withdrawn your question. All right. Any other questions or comments? All right. Seeing none, we're at the end of the agenda. So again, we'll be able to give everybody some time back, but appreciate your involvement and the great work that you're doing on the ground in your schools and with your community to improve the care of kids and addressing their mental health needs here in the state of Texas. And so again, thank you. We will continue to have conversation on a couple of these items. We're going to be approaching a time coming up where we're going to need to work with you to develop the budgets, but we'll have more of that coming up in the subsequent meetings. So again, appreciate your time and hope you have a great day. Thank you.
Thank you all.
Thank you.